Bore da, croeso I gyfarfod Bod Iechyd Prifysgol Cymraeg Morgannwg. Good morning and welcome to the bi-monthly meeting of Cymraeg Morgannwg University Health Board, which is being held in public. I would like to extend a very warm welcome to all those who have joined us for our meeting today, and for those who are joining via our live stream. Some practical points for today's meeting. As usual, can ask those who are presenting reports to take into account the fact that board members will have read in detail the reports before them for today. And can I say, we will be, because of the length of today's meeting, be looking to take a number of breaks throughout. I'm conscious we've got some very large items for discussion and determination today, and we will be breaking at lunchtime as well. Can I just point out that we do have some colleagues joining us via Teams. Neil Mesher, Councillor Rhys Good, as I understand it, will both be joining us via Teams this morning. Also joining on Teams will be Lisa Curtis-Jones and Paul Dienick as associate members. Can I also offer a very warm welcome to Daniel Price, the Regional Director for Plaid Cymru, who is here observing the meeting virtually, and Daniel will also be contributing to our discussions as we go through the agenda. Can I also offer a very warm welcome to Dale Stolzenberg, our Assistant Director of Transformation, and to Carolyn Blockley, Head of Capital, who are here for agenda item 3.1. And if I can just move to apologies for absence, there'll be no apologies for today's meeting. So I think there may be one or two people missing, but we haven't had any further apologies this morning. I'll just move on to item 1.3 under declarations of interest. I have received advance notice of one declaration of interest from Sarah Medlicott, our associate board member, in relation to item 3.1, the options appraisal for the future of health services in the Clinby Valley. Sarah, I'm grateful if you just outline the nature of the interest before we note it for the record.
Yeah, just to say that I've been a partner in Bronigan Surgery, providing primary care services within the footprint of my stake hospital for the last 10 years, and I've been a GP in the area for the last 25 years. Retired in December from the practice, so no longer have an interest there. But I am still a freelance GP, and up until the 8th of May, I've done a little bit of sickness cover in Bronigan Surgery.
Thank you so much, Richard. Lauren, thank you.
Yeah, aware that you've received some questions around our health visitor strike action, so just to declare membership of Unite Union.
Thank you.
Yes, same as Lauren, Unite Member.
Thanks, Rachel. Stuart?
Similarly, Chair, Unite Member.
Okay, thank you for those declarations, much appreciated. We're just going to move on to the issue of questions from the public. So before I turn to the main agenda items this morning, we have had, in advance of today's meeting, a number of questions from members of the public. We received one question in relation to the nature of the meeting being held today, and we have issued a response to the questioner which clarifies the nature of this health board meeting and the distinction between public meetings and meetings held in public. And as I've said earlier, for this meeting today, we are live streaming this meeting to ensure that people can access and view our proceedings today. We've also received other questions in relation to the options appraisal for the future of health services in the Clinby Valley from local elected representatives, and I'm proposing that we address those questions following the presentation under item 3.1. There are other questions received today that are in relation to items that are not earmarked for discussion at today's meeting, and I will deal with those at the end of the meeting. And there are a number of questions that I will need to respond to. Okay, item 2 this morning, the consent agenda business items. I know that colleagues will have gone through the consent items towards the end of today's agenda. If there are any matters that you want me to bring forward into the main part of the meeting, could you just indicate now? No, content to leave them where they are, thank you. Okay, item 3, improving care. We are now going to move to today's first substantive item under 3.1, which is the options appraisal for the future of health services in the Clinby Valley. Claire Thompson, our Exec Director of Strategy and Transformation, along with Dale and Carolyn are here to talk to this item. and there is there are a whole series of reports and appendices along with the presentation that we have to the board today. So Claire, I'll hand over to you. Thank you.
Thank you, Chair, and colleagues will be aware that the pack has gone through the Strategic Development Committee, so there has been a degree of scrutiny of that, but today we want to walk you through a presentation that outlines the content of those papers. So I really wanted to start by setting out the strategic context for our discussion today. Oh, we need to say next slide, please. Sorry. So as a health board, we're committed to developing and improving services for our communities, reducing the health inequalities that for too long have led to some of the poorest health outcomes and lowest life expectancy in the country. We are directed nationally to increase service provision locally and to reduce reliance on acute hospital services by modernising provision and transforming the way we offer our services. We're required to take the needs not only of people using our services today, but those of future generations into account when we're planning and designing services. That needs different approaches, thinking and facilities as we modernise our offer. As a board, we have a duty to consider how we use the public money that we're entrusted with and for which we're accountable in the most efficient manner to deliver the best outcomes for the most people. So today's discussions are to agree a preferred option to go forward with the provision of health services in the Clintby Valley. But whatever the outcome, there'll be further work to engage and involve the community in designing future services. Next slide, please. So everyone around this table and within the Health Board shares our strategic commitment to building healthier communities together. The journey to do that is not without compromise, but a lot of our dialogue is the language of deficit, of poor health outcomes, of unsustainable services, of deprivation and of loss. We want to focus on the opportunities presented by the strengths of our communities and the expertise of our people. We know that the strength of local voices, the bonds and the community spirit provide strong assets for us to collectively build on. Doing that means that we have to hear feedback, that making difficult decisions may not be universally popular. We should not shy away from that, because together we can build new opportunities based on the strengths and the assets of our communities, whilst being respectful of the history and legacies of those communities. Next slide, please. So we know that as our population gets older and sicker with more complex health needs, we need to move away from a hospital-based model of care to one in which people are able to be cared for at home with more support. That means we have to fundamentally reorientate our service provision away from the primarily hospital-based system to one that is built around offering a wider range and higher intensity of care and treatment in our communities. The Clintby Valley Health and Wellbeing Centre proposal then is one of a number of hubs that can provide bases for integrated health and care teams, primary care GP-led teams, the voluntary sector, mental health and current hospital-based specialists. The facility would enable greater collaboration between these teams based around the needs of their communities, whilst also shifting increasingly to prevention as much as treatment. Go to the next slide, please. This proposal is therefore one of a number that will need to come forward if our health services are to be sustainable as part of a new vision of services for people across the CTM geography, which you can see on the slide there. This future model describes a different way of thinking about and delivering services based around the needs of our communities rather than a historic model of primary and secondary care services. In this model, we see the fifth layer of hospital bed-based services reserved for the most complex and critically ill patients. And the establishment of facilities like the Clintby Valley Health and Wellbeing Centre at levels 2 and 3, providing the urgent community response and integrated locality teams that will enable patients to be cared for in their own homes. I'm going to pass now to Dale, the programme lead for the Clintby Valley project, who will give a presentation that will walk you through the detail in the pack. If we move to the next slide, please.
Thanks, Claire. Morning, everyone. Obviously, there's a great deal of detail in the pack you received. So what I've done is pull out some of the key points rather than spend hours with you going through what you've already read. So I'll say, if we can move to the next slide. So purpose of today's presentation and discussion is one, to set out the strategic case. So as Claire said out why a change for Llanby Valley Health and Wellbeing Centre is needed, demonstrate the community pre-engagement that we have undertaken, summarise the options work that's been done to date, confirm the preferred site with you, and then seek your agreement for that preferred option progression of a full strategic joint outline business case. So I think the key here is the board is not being asked to approve any submission into Welsh Government at this stage. A full SOC OBC will be brought before public board upon completion and indicatively before the end of this current financial year. Next slide, please. So we'll take you quickly around the why, how we talk to people, the starting point to then meeting local needs. So if we can just skip to the next slide there. So in terms of the why, the Llanby Valley, as much as Bridgend North, does experience poorer health outcomes. There is a lower healthy life expectancy. At best, it's seen as 16 years lower healthy life expectancy compared to 8 miles down the road. At the top end, it could be up to 20 years. There is a real challenge there. It is an ageing population, as it is much across Bridgend County and Wales as a whole. Because of these issues, local health inequalities are widening. But also we need to meet national and local strategies as well, including CTM 2030 that Claire set out. But also it's the condition of my state community hospital. There were 3 million maintenance backlog when CTM took over the hospital in 2019. That has come down, but it is still substantial. Next slide, please. So obviously, since January 2023, we have undertaken extensive pre-engagement with the local community through a variety of different means, and there has been wide stakeholder reach, digital to in-person events to one-to-one meetings with community groups, just to name others. Actually, we actually acknowledge the local feedback from FLICE, the work they've done recently, which does highlight a number of issues, many of which sit outside the scope of this project, whether that's transport, access to GPs, access to wider issues. They will be addressed, but not necessarily within the scope of this project. And the key thing is here, moving forward, we actually do want to engage all voices, particularly those seldom heard groups, particularly younger people, those with families and children, and who often don't engage as strongly in these sorts of engagement activities as other demographics. Next slide, please. So as I said, we initially considered how we could redevelop my state community hospital via the integrated rebalancing care funding, which is done through the Regional Partnership Board and Welsh Government. As part of that work, we appointed external partners then to help us develop the project and understand the scope and the costs. But ultimately, the objective is to improve physical and mental health outcomes in the Llanby Valley by delivering more services locally, reducing avoidable hospital admission and use, and enabling earlier, better access to not just health services, but local authority and third sector integrated services as well. Next slide, please. So responding to the ambition that the Health Board has, responding to the needs the local community has, we are obviously talking about a much wider range of services being delivered in the Llanby Valley than are delivered now. I won't go through that in detail because there's a long list and I'll be here until the end of my session. But ultimately, the key changes there, the addition of urgent treatment centre covering minor injury and illness, radiology, GP provision, and then the key thing is enhanced outpatient, so a wider range of outpatient services, as well as then integrated children and integrated adult teams with local authority and third sector partners being based actually in the Llanby Valley, where they aren't now. Next slide, please. So just for a summary, the list of services I just outlined are there on the left. Column 2 is the current, but the key thing is here the number of green ticks that exist on the far right column to show the increase in services locally. We've done extensive engagement through user group workshops with local teams as well as local authority and third sector to develop these range of services on a need to deliver these on a revenue cost neutral basis. Three red ticks I will mention. Community dental services, obviously the development of a Bridgend Health and Wellbeing Centre hub has a huge range of community dental services there, which will act as the hub for Bridgend County. And also there isn't a demand for a dedicated service in the valley, given the numbers of patients coming through. Community pharmacy, community pharmaceutical needs assessment says actually there's enough in the valley, so there's no need to take that forward. And then obviously community beds, which I know is a hot topic for many in the community, which I'll cover on the next slide. Next slide, please. So as I said, we absolutely recognise that the return of community beds to Flint Valley has been an important part of the engagement, pre-engagement since 2023, including obviously through the FLICE feedback you'll have all seen. We absolutely hear people's concerns and recognise, again, along with our local authority partners, that the provision of community beds should be available as close as possible to where people live. We are working with BCBC to essentially understand how beds are spread right across CTM as well as our other partners to ensure they do provide safe, accessible and good quality care to meet what we recognise are changing needs of our population. And the key line there is we hope to share more with the community around community beds this summer. Next slide, please. So going back to 2024, we undertook quite a large range of user group workshops with all the services I've mentioned. We developed 5 long list options to REVA 1, which is essentially a preparation and brief stage, which does include informed cost estimates. As you can see from the top right hand side there, they started at 53 million, rising all the way up to 80 million plus. They were discussed in an options appraisal workshop with representatives from all our partners, including the Health Board back in 2025. No preferred option was determined because we wanted to, at that stage, understand our budget availability and budget discussions with the Welsh Government IRCF team. That conversation was held in September 2024. And the feedback that we had was, one, that these schemes were significantly more expensive than the anticipated capital funding that was available. That stage was an indicative guide of up to 30 million to help us guide shortlist options consideration. And also the community bed provision was not included within their funding scope. And understanding what the indicative budget was is important, because what we wanted to avoid is abortive costs and what other schemes in Wales have seen where they've got through to full business case and they've been sent back to the drawing board because ultimately the schemes were far too expensive for them to move forward. I will flag here on all these options, and we'll see it moving forward, there are roughly £6.4 million worth of abnormal or site constraints associated with redeveloping My State Community Hospital. So that is retaining the hospital facade, it's a new substation for the electricity demands, it's car parking, it's etc, etc. And it also includes then almost 2 million, 1.5 to 2 million for temporary accommodation, the existing services on site that would need to be relocated elsewhere, including Bronigan surgery, should we move forward with the development of My State Community Hospital. Next slide, please. So based on the feedback from IRCF, we looked at alternative options to make sure we could deliver a scheme that was of value to the community. That included value engineering and schedule accommodation, so really squeezing the space that we needed to deliver all those services, as well as then looking at alternative option sites for comparison. So we identified the former Revlon site near Wenny Road, My Stag, after discussion with Virginia County Borough Council. The reason for that site is it needs to be accessible and close to town centre with good transport links. There aren't many available sort of sites within the community, which is why conversation with BCBC, that site was identified. In October 2025, the Welsh Government team agreed that the Wenny Road site could be considered as part of the shortlist to meet the desired project objectives and outcomes. And then approval was also granted for additional business case fees to essentially allow us to consider that option as part of the shortlist. And that was against the capital funding requirement potential of 33.9 million, which I'll come back to in a moment. Next slide, please. So this is for illustrative purposes only. But just to give a sense, you have My State Town Hall in the centre, which is the centre of town. Top left there is My State Community Hospital. It's 0.7 miles up the Leith Road, up the hill there. 3 options we'll bring forward in a moment. And then to the bottom right there, you see the Wenny Road site, which is roughly a mile from town. And you can see it's right on a railway station there as well. So in terms of proximity to the town centre, they're more or less equal in terms of distance. Next slide, please. So I won't focus too much on this. You'll have all seen this in your pack, the criteria by which we assessed this at our options appraisal workshop back on the 8th of May 2026. Next slide, please. So as I mentioned, that 33.9 million, that was accepted and is considered to represent a reasonable assessment for a scheme project of this size and complexity. It is sufficiently robust for application within the options appraisal process. It was used to score each of these options. So I think the key thing is for options 3 and 4, which you come to in a moment, the value engineered schedule accommodation, the one we squeezed to get to a reasonable size there, was the option on a like-for-like basis, it's the same for options 3 and 4 for a real true comparison between the two options. So if we can move to the next slide, please. So option 1, all schemes from a Welsh Government perspective need to show, demonstrate they do nothing. So what if we did nothing at the site, which essentially just maintains current services and addresses backlog maintenance? That comes in just shy of 1 million. Positives, it does retain the use of the building for health services, obviously the lowest delivery risk, and it doesn't disrupt services. But in terms of negatives, it doesn't meet our project objectives or those of IRCF. Obviously, we can't then deliver more services, and ultimately there's a risk of closure in the site in the medium to longer term due to the required infrastructure investment beyond just the backlog maintenance at the site. So that's option 1, to do nothing. If you can go to the next slide, please. So there we have a do minimum, which essentially is your backlog maintenance, maintaining services. The former Thinby ward, we develop that into a usable space, not as a ward, but as a usable space. And then it does include some other site improvements, like trying to address roof issues with leaks, etc., etc. To say that comes in just shy of 5 million there. Again, you know, it does retain the use of the building. It does require a smaller amount of IRCF capital funding, and you do have the potential then to pilot some new services in that refurbished space. But in terms of a negative perspective, obviously it doesn't meet our desired project objectives, all that, and it only meets IRCF on a limited basis. You know, to essentially target everything that we want to support people in the community. But obviously there's then, as part of our limited integrated service and enhancement with our local authority partners and the third sector, and ultimately large parts of the building would also remain unusable for patients and staff, so essentially addresses some of the issues of the site. So then if we can move to option 3, please, thank you. So this is a Trinity Valley Health and Wellbeing Centre at My State Community Hospital. This is the full redevelopment of the site and includes all those proposed services I talked about. And that comes in at just over 40 million there. So again, positives, it does absolutely retain the use of the building health services. It does meet IRCF funding requirements, policies, and obviously our wider aims and objectives. The negatives here, against that 33.9, it is unaffordable. As I mentioned, there is 6.4 million on abnormals and site constraints. There is still limited public transport to the site, and we still need to address the local covenant covering the use of adjacent land, the green space, because we know the existing site doesn't have the required spaces for parking, and we still need to overcome that covenant and all requirements for parking on new green space. So we don't know the cost of that, so that is a risk in terms of that 40 million figure. And then we go to option 4, which is essentially a new build development with all those services for a new site at the Welly Road. So that comes in at 34.2 million, so marginally over that 33.9 that we talked about. But from this perspective, there is positives, is capital affordability. In new build development does present opportunities for cost savings through the build, modern methods of construction, which could be potentially identified through the next stages. There are strong transport links. The key thing is you have the railway station immediately opposite, right next to the site, BCBC, and also planning on building a transport interchange with bus services. They'll stop there from up and down the valley. There is minimal disruption to obviously local health services during the construction. So My State Hospital would remain open during that period. It does meet IRCF and our wider aims and objectives. And the key here is all existing local health services will be retained and then enhanced. Absolutely negatives, recognise there is a transition away from services from My State Community Hospital to a new facility. It would require a longer term and robust strategy for the site. For awareness, there are 2.4 million worth of abnormals and site constraints at this site, just for completeness. And we obviously recognise there are some community concerns regarding the service location and site change that again would need to be addressed through ongoing community engagement. Next slide, please. So taking that into account, see, we went through an options appraisal workshop on the Friday the 8th of May with a wide variety of representatives, and the preferred option identified was the Trinity Valley Health and Wellbeing Centre at Welly Road. And there were 3 clear benefits identified during that appraisal workshop that meant this option ranked highly. 1, capital affordability at SOC stage, and obviously it talks about the opportunities for optimisation then in terms of build as part of OBC. There will be excellent transport links with that transport interchange, and again there is minimal disruption to local health services. And on the right hand side there is the scoring, 57 out of 70 for option 4 compared to 48 at option 3. But ultimately, what does this mean for the Findlay Valley? It means more services for more people locally, better access to more services locally, better joined up support across different organisations, third sector, health and local authority, and ultimately what we're all aiming for is better outcomes for more people addressing those local health inequalities. Next slide, please. So in terms of the purchase of the UHB Road site, we have agreement with BCBC that is subject to DD valuation and subject to the approval of the full business case. So that site will be made available for us to move forward depending on your decision today. And actually, in terms of the future of the MyState Community Hospital site, as you can imagine, we have started early engagement and collaborative work with BCBC to develop and think about a sustainable longer-term future for the hospital site. Obviously, the clear intent of this work is to ensure that the site continues to serve the community in a meaningful way. And it does include then obviously the consideration of community-focused healthcare, wellbeing and other public complementary uses. In terms of what would happen next, obviously, depending on your decision today, you come forward with a full SOC OBCP consideration before the end of this financial year. That will then go to Welsh Government and subject to their approval, followed by final business case. All being well, that will be completed in 2028. Construction will then start with anticipated opening of around 2030, subject to approvals and planning, etc. Next slide, please. So obviously we talked about engaging the community. That will be stepped up and enhanced moving forward. As part of this, pre-engagement has tested community priorities, including access, service range, location, etc. We want to engage all voices, as I've said, particularly those seldom heard groups. As part of depending on your decision today, we'll come forward with a comprehensive engagement plan developed with FLICE to be able to take this forward in a meaningful and effective way. And final slide there, please. In terms of key risks, these are identified in the paper. I won't focus too much on these. It's just one to be aware of, capital affordability, etc. And the key thing here is scope creep. Inflation will inevitably happen, but the key thing is not to grow the number of services in space that you need, which is always a challenge. And next slide, please. So, in conclusion, there, I won't focus too much on the rest, but just to say the proposed in front of you for preferred option today will enable a step change in how health, local authority, and third sector integrated services are delivered. Does support prevention, early intervention, admission avoidance, and then improved access. That's obviously potentially reducing pressure on acute services at Princess of Wales Hospital and Bridgend. So if we can move to the next slide there. So in summary, I won't focus too much there. Essentially, the ask today is for public board to approve progression of this preferred option to the development of the full SOC OBC business case, following the 5-case business model, then for subsequent consideration by you and then by Welsh Government next year. Thank you.
Thank you, Dale, for the presentation. Before I come back to Claire, I just want to say a huge thank you to you, because this is a colossal piece of work. The level of detail, the consideration, the issues that have cropped up during a long process of consultation with local elected members and with the public, has been factored into this. And this has been a superb piece of work. Well done. And Dale, thank you on behalf of the board for the starting point. This isn't the end point. This is in many ways potentially the starting point, subject to what the board may determine today. But clearly there is a significant ambition for us to be better at delivering services for and with people in a valley that has for too long not had access to the things that it needs to support the health and well-being of the local population. And I think the fact that this is before us today demonstrates the ambition of the board in attempting to be more visible, more local in how those services are delivered to improve access and to improve outcomes. So Dale, thank you very much. I am going to turn to Claire. I did mention that we've received a number of questions in relation to this item from elected members. So Claire, I know you're going to handle the questions and provide those answers. Thank you.
Thank you, Chair. So we have a number of questions in advance of the board, all from elected representatives. A number of the issues that are raised have been covered in the presentation, so apologies if this is repetitious, but for the sake of transparency, I wanted to make sure that we had gone through all of those. So in relation to beds, Hewler Anker Davies MS has asked for an update on the concerns around the provision of community beds. So As a health board, we understand the desire and share the desire of communities to have community bed provision as close as to their homes as possible. And we do have longer term plans in train with local authority partners to address that. In the shorter term, we're working out specific proposals around community health beds in Bridgend County Borough Council. And as Della said, we hope to be able to share those early this summer. Sarah Evans MS has asked what considerations and modelling we've undertaken for step down and or respite facilities and about the future of community beds for current and future need in the Finchley Valley. So we've commissioned a complete demand and capacity review for community beds as part of our work through the Regional Partnership Board with local authority partners to inform those longer term plans. Our internal health board modelling indicates that demand for the type of beds historically provided at Maesteg Community Hospital in the whole of Bridgend County Borough Council averages 3 admissions per week, which clearly doesn't equate to a standalone health facility in the Finchley Valley being sustainable. In relation to engagement, Councillor Ross Thomas, chair of the Maesteg Hospital League of Friends, has asked how we can be sure that advice's feedback will be considered. There was an unintentional omission in the papers that were initially released. The Clyce appendix was added on Monday of this week and has been part of the public board consideration and papers for consideration today. Sarah Evans MS has asked how she can be sure that advice's feedback will be considered, how we will take further engagement seriously, and written confirmation of a plan in relation to that. Rankin Davies MS has said that he looks forward to hearing what the next stages of engagement will be and how residents and others can be involved in shaping the proposal. So as we've said, we're committed to engaging all voices, particularly those from seldom heard groups in engagement activity, whilst building on the existing work to strengthen trust and confidence in our communities. We'll continue to work in partnership with Clyce and a comprehensive engagement plan informed by their feedback and existing input from communities and stakeholders. It is currently being developed. Subject to the board's decision on the preferred option, that will ensure meaningful opportunities for involvement of all, and the final plan would be shared. So we recognise that listening to and responding to public feedback doesn't always mean that every request can be implemented. However, all considerations are carefully considered and do play an important role in shaping proposals. Sarah Evans MS has asked how we can be sure of continued community engagement when it has been lacking for some time. Councillor Ross Thomas has mentioned that there has been a lack of direct two-way communication. So we hope it's come across today that we really do recognise the importance of ongoing community engagement and want to reassure stakeholders that engagement has been taking place since January 2023 using a range of approaches. And that's all outlined in Appendix A of the board reports today. So those methods are aimed to provide opportunities for as many people as possible to share their views on the future of health provision in the Finchley Valley. And we would also want to recognise that meaningful engagement can take many different forms, not solely large public meetings. Sarah Evans MS has said that the Health Board committed to elected member engagement prior to presenting the options appraisal to board. She's asked why that commitment has not been honoured and why the paper is being presented prior to the said promised engagement. So elected officials were provided with pre-briefing materials on release of the board papers. The determination of the preferred option will support the framing of engagement, including transparency about what is and is not within scope at each stage of the project. And it will provide clear separation between decisions on service provision in the Finchley Family and Health and Wellbeing Centre, any need to plan the future of the Maesteg Community Hospital site, and the provision of community beds across Bridgend County Borough. So finally, just some general comments and questions. So Rankin Davies MS asked us to respond to concerns over the future of the community, future of the community hospital site. So dependent on the outcome of today's meeting and subject to approval of a business case for the proposed solution, Maesteg Community Hospital would close as a health facility. In the event of that happening, we are committed to working with partners to find a future use for the site that includes the consideration of community-focused health, care, wellbeing or complementary public uses. Sarah Evans MS has asked how we will mitigate the significant site constraints associated with the preferred site. The papers refer to significant site constraints at the Maesteg Hospital site, not at the UNE Road site. There are constraints at the UNE sites and as with any other construction project, those will need to be considered and managed through the REBA design stages. Finally, Councillor Ross Thomas has asked why we aren't waiting for the new Welsh Government to constructively challenge the proposal. So recognising that work on this project has been taking place for over 3 years, and this represents a once in a generation opportunity to access investment, it's important that we continue to develop this project without further delay. Welsh Government will scrutinise the project when we've proceeded to the strategic outline case, outline business case stage, and updates from today's decision. I should say, we talked about stock OPC, didn't we, during the presentation? That is the strategic outline case, outline business case, stages of the standard 5-stage business case model, just for public awareness.
Thank you, Claire. Before I come back to board members for any comments or any questions to Tim, I'm just going to check in with Daniel from Clyce to see if Daniel wants to provide any perspectives, bearing in mind that Clyce have held a number of engagement events. Thanks, Dan.
Thank you, Chair. Obviously, follow your approach. Papers are taken as read, so I'm not going to outline anything in the paper in detail. What I would like to do is just outline Clyce's role in service change, which is different to the predecessor organisation. We no longer support decisions or not. Our role is to hear from the public and share those views with yourselves for consideration. So I hope you take them on board. I have had feedback from representatives in the same way as Claire's outlined. You've had questions, and they have confirmed that our report and our cover letter does summarise the sense of feeling in the community, and that does cover both the strength of the feeling and also the content. I am pleased to hear the commitment to engagement throughout that presentation there, and I also look forward to working with Claire in our meetings on the commitment to the beds, and I appreciate that might be one of those things that are outside the project scope, but is very important to the community. So just to summarise, it would have been helpful if our report had been included from the outset, but I acknowledge, Claire, thank you for bringing that up. Chair, I did say I'd look for further survey responses, and anything we've heard in the interim between the report being submitted, I can confirm I've had nothing new in since through the survey link, so the report is as it stands and does not need to be amended. And therefore, just the reminder that the key issues in our report are the community beds in Llinvi Valley, which you have addressed, the accessibility of other locations used for services in CTM, and we've experienced that with Ysbyty George Thomas and those type changes, but that is in the report, and also then the future of Maesteg Hospital, which Claire, you've helpfully just addressed in response to those questions as well. So yeah, I hope our report helps, and I look forward to board's deliberations.
Thank you, Daniel, much appreciated. The first question is from Rhys Good. Thank you, Rhys.
Thank you, Chair. And just to say, first of all, thank you to Claire and Dale for all of the work. I know there's a huge amount of work gone into this. I think I do have to sort of reflect on my fellow elected officials' views that have been delivered to the board this morning. I think there are a lot of concerns and a lot of learnings that need to be taken away from this in terms of how we've engaged with the public. As Dale will be very alive to, as a fellow Valleys boy like me, our communities in the Valleys, particularly in the north of Bridgend, have for a very long time felt that things are done to them, not with them. And that has led to, rightly or wrongly, a culture where I think there is a default to feeling like something bad is going to happen. And while that isn't the health board's fault, I think it is something we need to be more alive to when we are talking about services in these sort of areas. And I mean, I think particularly on this, you know, we are improving the services in the Llinvi Valley. It is a good thing. It's a really positive thing. And I know that the people in the Llinvi Valley will be really welcoming of that. But I think the way that they have obviously felt they've been engaged with and can be seen in the Clyce report doesn't reflect, I think, what the aims of us as the health board are. And I know that everyone around that table is looking for the best outcomes for Llinvi. But we really, going forward from this, have to be looking at better ways to engage them going forward, because this is a really positive thing. There are really good things happening, but we have to make sure that they are feeling like we are taking them with them and that we're doing it with them rather than doing to them. And I think that's sort of my reflections on where we are now, that, you know, in a sort of all equal world, a new facility in a valley community that's delivering new services is amazing. And we shouldn't be losing sight of that. And my concern here is that we have lost that positivity within the community already. So I just wanted to raise that. I think we do need to have a bit of a wash up from the initial part of this on how we got that engagement and what we can do next to make sure that everyone in the Llynfi and the wider part of North Bridgend feels like we are doing this for them and with them rather than taking something away, which is what I think, unfortunately, is the situation that many people believe we're in at the moment. Thank you, Chair.
Thank you, Rhys. Before I bring other members in this morning, just to reflect on those points in terms of how we engage as an organisation, there's been quite significant work to engage with both elected members of the Senedd and of the local authority and of those community groups that we have so far been able to meet with. However, the people who have engaged in this thus far have been a very small number of the overall number of people who live in Maesteg and the Llynfi Valley. And our job is to ensure that we hear all the voices. And we must ensure that we hear the voices of all of those people across all of the age groups to ensure that this isn't just about one section of our communities in Maesteg and the Llynfi Valley, but that we are able to hear the voices of all of those people who wish to engage in this work. And that is our job as a health board now, to set out a really ambitious engagement plan that takes this beyond those people that we have so far engaged with. And, you know, Rhys, I know that the board is really aware of how people feel. And the meetings that we have had with a variety of community groups have told us that for too long, they have felt done to, that they have lost things locally to them. They have seen a deterioration in their local community, and it's something that really hits home very hard. And we have to be absolutely committed to that long-term engagement so that we work with people to demonstrate the range of services that we are able to deliver locally, the impact that it will have positively for more people locally than we've been able to do thus far, and to try and do that in a really collaborative way. But at the moment, the number of people who have engaged is a small percentage of the overall population number, and our job now is to further that and to deepen it. And Philip, do you want to come in at this point? Yeah.
Sorry, thank you. Just to say, I don't intend to rehearse what's within the papers, and thank you very much, Dale, for bringing up the point of health inequalities and investment for the future. We know from the paper, we know from the statistics, Bridgend North has statistically significantly higher rates of chronic conditions amongst adults, but for children born today, they deserve services that meet their needs for the next 100 years, right? Because many of them will live to 100 as well, many of the children born today. We know that Bridgend North has statistically higher rates of low birth weight and lower rates of breastfeeding than the rest of CTM, than the rest of Wales. And we know that has a range of impacts. But what isn't in the paper, the child measurement programme, the latest data was released 2 weeks ago for Wales. So this measures children at the age of 4 and 5, reception age, their height and their weight to find their BMI, right? The latest data shows that in Bridgend North, for this cohort, obesity increased from 11% in 23-24 to 14.9% in 24-25 in Bridgend. And there's a clear link to deprivation. The Bridgend North cluster has the highest obesity rate at age 4 or 5 of any cluster in CTM. So that the previous statistic was for Bridgend. So Bridgend North is at 18.2%. 1 in 5 children at the age of 4-5 have obesity, right? And that's got lifelong implications for their health, for their healthcare utilisation, but also for their quality of life as well. We can't persist with historical models of services because we need to evolve them. They need to meet the needs of future generations. And whilst health services only equate 20% of health outcomes, it's linked to the wider terms of health in terms of employment, education, etc. This development suggests a significant step towards meeting population needs. And just to underline Rhys's point, it does provide an opportunity as well about how we work with communities in the future as well to improve population health, because it's something that health services can't do alone. It's something that we all have to do together. Thank you very much.
Okay. Yes.
Yeah, on the engagement, I think the last survey was really useful because it really brought out what the issues, concerns, themes were. And I think the Appendix 1 shows a huge amount of engagement and a lot of sessions that have been had, but didn't pull out the themes for me. So I'm just wondering, as we move forward and engage, could we have more around what the themes are coming out of those engagement sessions? Would that be possible in terms of lessons learned?
Yeah, absolutely. Paul?
Yeah, so I think that it's absolutely clear, and Reece made a really valid point, and I think we would all agree that this is a proposal that is always going to have a differential of views in communities, and the really important thing, depending on what we decide today, is that moving forward we do whatever we can to engage the community in its broader sense, and this is part of the challenge because often some of our younger population don't necessarily always engage in sessions around these sorts of topics because they don't think it's necessarily relevant because they're not using those services. So why do I need to go along? So there's something for us about how do we go out proactively into the places that those people are, because Dan will know better than us that, engaging certain groups of populations is often very hard to do. And that's not to say that we don't also want to listen to the voices that do present, but there's something about, as Philip's rightly said, this is about looking at this in the round. We've got a responsibility for the whole population. But we absolutely need to make sure that whatever we agree today, there is a really clear plan for engagement, that is done in collaboration with people like Slice, with other community groups in my stag, and also broader groups. So, another group we haven't talked about yet is our staff as well, because staff work in these facilities, they work in the locality, in the community setting, they have got experience firsthand of dealing with patients and interacting with patients. So it's really important we hear their views as well. So whatever we do today, I think our commitment absolutely is that we bring back probably to this group or to SDC the engagement plan that will underpin the next stage of this development, because I think we've absolutely heard really loud and clear the concerns. I just also wanted to say, obviously, what we are talking here today is about the options around the next phase of this development. As Dale rightly highlighted, a lot of the anxiety and worry in the community is about what's going to happen to the hospital site. And I think there is a secondary conversation, dependent on the agreement today, about how we manage that conversation. Now, we've had a number of conversations with Bridgend Borough Council officers about how we could work together on thinking about that site and what it could do in the future for the benefit of that community. So I think that's another secondary. So I'm not trying to decouple the thing, but I think it is important that we look at the two things separately. There's what the future model of care could look like and where that's delivered, and then the consequential impact of, and if it's at Wenny Road, what then do we need to look at? And there will be a different sort of engagement process, I think, for the conversation about the hospital site, to then an engagement plan for the development of whatever the new centre looks like. So I just think it's really important we don't, because there is a risk that we muddy the waters and blur the things, which I think actually need to be kept separate for the purposes of our process next steps.
Great. Yeah, thanks. I'll come to Sarah first. Thank you.
I was just going to make the point, I suppose, being the voice of the community a little in this setting, that we've been consulting since 2023, and if those voices are not coming through, I think we have a duty to say that we haven't been listening to those voices, and how are we going to listen to them in the future? Because we're saying we're only listening to loud voices at the moment, but those other quieter voices and the people who don't represent themselves, we've had 3 years to listen to them, and we need a better way of doing that. I think the services in Prospect are fabulous, and investment in the community is absolutely, definitely what we need, and I'm wholly in support of that. I suppose if I were somebody asking questions, I would say initially the consultation was based around keeping community beds, and those community beds are now no longer part of that. What assurance, as a concerned person, would you be able to give me that the desired outcomes for services in what's proposed will not suffer the same attrition going forwards? So if I would be saying the desired outcome of an urgent care centre, how can I be reassured, given my experience in the past, that you're not going to, at a future date, come back to me and say, now we've repurposed this, there's not the funding for the urgent care, and all we can do is replace the capacity that's there currently. So just looking for some reassurance around that.
Thanks, sir.
I mean, I think that's an absolutely fair point, and you know, and this is the challenge, right, with time, because the months that go by, the years that go by, and as we all know, cost inflation is significant. It's getting only even more significant. I think we've got to be absolutely clear from today what are the red lines effectively that are services that are non-negotiable have to be included, and I think that many of those ones that have been articulated by Dan in his presentation are absolutely fundamental, Sarah.
Yeah.
You know, we heard loud and clear when we engaged communities a while back when we started this process that, you know, people have to travel a long way if they've got an urgent need to Princess of Wales Hospital. For many people in the Slimbie Valley, that is not possible because they don't have a car, or if they can get on public transport, it takes a very long time. It's very costly. So the more we can provide alternatives for those people in that community, the better. And I think absolutely the model is really important. I think it's an opportunity also, as you all know, this is to talk to the practices about this as well, because there's an opportunity to work collaboratively with the practices on that model as well. So I think you're absolutely right to highlight the risk, but I think we've got to, in making the decision today, we've got to give it an absolute commitment that those services that are described in that paper are absolutely critical and will need to be maintained. But it also highlights the need for us to get on and make decisions relatively quickly and keep the process moving, because this money is sat there allocated to this project in government, but we can't afford to lose out. This is £30-odd million of investment in the Slimbie Valley, which is a once in a lifetime opportunity to really make a step change in service provision. So I think it highlights the need for us to get on and keep the pace behind this.
Suppose I was clarifying, it's the brackets that you've got core service and you've got desirable.
Yeah, so there's two things there. So so you'll see the core are the ones listed there.
Right. So desirable is what the added value is.
So what I'd say is we have, you know, that list wasn't drawn out of the air. We have engaged extensively, one within the health board and all the teams, within the care team and others. We've engaged with local authority and third sector. So what's in there has the commitment and buy-in from those services that we've listed. You know, right from the outset, everyone knows revenue cost neutral, that we've different ways of working within the current allocations that we have to deliver these services. And that's what everyone's bought into. So now it's up to us to deliver those in terms of a full business case moving forward. But yeah, they aren't there just by chance. They're there through ongoing engagement right across our partners and in health to make sure that they are as appropriate as they should be.
Thanks, Laurie.
Thank you. So just coming back to the service model, I think, you know, the concerns that came through in the questions and the FICE report are, you know, a lot of those relate to community beds, which is understandable. So Claire's responded to some of those in terms of the responses to those questions, but I do think it's worth adding that, you know, the evidence and the research shows us that the best beds in the community are the ones in people's homes, and this model allows us to really focus on those services and embedding them in the community to support as many people as possible to stay at home for as long as possible for the vast majority of the time. And then just a comment in terms of building on the health inequalities that we're seeing in the Slimbie Valley. So this model allows us to absolutely embed that health protection, prevention, early intervention services into this area, and it should hopefully make it much easier for the community and especially children to attend and access those services.
Thank you, Lauren. Hayley, and then to Patsy. Thank you. Thanks, Hayley.
Thank you. Thank you for the presentation, really good today, and agree with sort of what everyone said about sort of the need for this. I think I'd say and preferred option does sound amazing. I guess sort of my point isn't really on sort of the discussion of what's been asked to decide today, but just more about that engagement section. And when we started this sort of back in 2023, we had quite a lot of engagement, and then that's kind of like pinched up a little bit. And Reece has been saying that people want us to engage with them, but do we know how they want us to engage with them? Because obviously there are many different ways of engagement, and if we're only just using that one part, then that's like we're only hearing one voice, isn't it? Do we know how they want us to do that?
Yeah, I mean, Simon and I want to come in on that.
Yeah, I guess the first thing to say is will be no one size fits all. So, you know, engagement to date has taken place over a variety of kind of platforms and methods, including digital, face-to-face kind of online stuff as well. Going forward, that will only have to broaden further. There will have to be and there will be a particular focus on those groups we haven't heard from yet. We know that, like all organisations trying to engage communities, and I know that Dan would agree with this from Fleiss's point of view, engaging with younger families, younger people is a real challenge for some of the reasons that have been discussed. We won't determine what all those platforms and methodologies look like just around this table. We need to do it in partnership, not only with Fleiss, but also with the communities as well themselves. It won't be a creation of that plan behind closed doors. It will be developed with the community as well, so that when we go out there and have those conversations, we can do so with the confidence we are reaching people in the right ways, using the right language, taking into account accessibility challenges that will exist in all communities, but there'll be certain areas within that area particularly where that might be slightly more predominant as well.
I guess I'm just interested that we haven't asked that question before. If
That's
we're,
my point.
yeah, absolutely, that needs to happen. Have we asked that question? And do we know? Have they told us how they want us to engage with them? And almost that might have been sort of nice previously, potentially, if we know that we're only getting those 55 people.
Well, the 50
said anything.
Yeah, the 55. I think you're referring to the Fleiss engagement. The numbers that have engaged through our own channels are far greater than that. So I think this has taken place over 3 years. It hasn't remained a static plan. It has. If you look at the appendix, the variety of ways in which we've engaged with people has changed and has been influenced by the questions people are asking us. I think being able to go forward, depending on the decision today, with a proposal allows us to be far more focused and targeted with our engagement as well. It will enable, I think, and will encourage more people to engage with us as well, because there's something more concrete that they can actually engage with. Yeah.
That's it.
Yeah, Paul sort of touched on my question around engagement with staff, and particularly clinical staff. I wonder if there is a clinical view that this move is necessary in order to be able to deliver the best clinical service to that population.
I'll bring Dom in on this one. Thank you, Dom.
Yeah, thanks. So I directly have some point I was going to make on there. First, just to say this fits very much with the Community by Design project that's the national plan. Applied have put out already in their first 100 days, haven't they, saying that communities where they really want the focus is why aren't we doing more for the community? This is exactly the sort of thing that we should be doing, and we know we should be doing, so it fits beautifully with that. So I would hope that means we get that support sort of essentially when it comes to that. But this is just one of those many evolutions of healthcare that Claire referred to. Of course, there are lots of other projects we've got, but this is that real challenge. As Philip's just told us about the obesity numbers on there. We've got huge amounts of chronic conditions, particularly in this one. We were talking about pain, weren't we, at the start? Huge pain you don't refer in because you manage it locally. There's a lot of issues that we can do, and by basing ourselves better in the community, we know we can deal with what those specific areas are, because I would guarantee that the conditions that they've got there are probably slightly different from the ones that we've got on the outskirts of Bridgend, on the outskirts of Merthyr. So we've got to be able to adapt and change. By having that community locally allows us to do that in a much better way. And it's not, and Reese's point there, it's not about doing to people, it's doing it with them. So understanding what their concerns, what their needs are from a health perspective, and what we're providing them to deal with those health issues. And that, I think, it comes in that next phase, isn't it, really, when we engage with all of the groups. I'd love to hear, from the postnatal sort of groups there, particularly what their particular issues are. We've got breastfeeding issues on there. What are particular issues with those who have a chronic condition, who have diabetes, who are younger, how we manage engaging with them. So in some ways, we've got to, if we do it from a health lens of health conditions, it gets us into those groups that we probably haven't done, rather than having a broader just community discussion.
Yeah.
So I think it's a real opportunity.
Yeah, it's the clinical view on the
sorry.
move is what I'm asking.
Sorry,
I don't know if it's helpful to say initially, right up front, GPs, community staff, all part of that engagement in terms of the needs and the offer that we want to make. As part of getting moving forward with the project, we've got clinical reps as project board that oversees this, and clinical reps on that. And as we go forward and get more to the nitty gritty, then absolutely those voices become even more critical, don't they, in terms of how we design and configure services. So yeah, they have been, they are, and they will continue to be.
Before I move, oh, sorry.
Sorry, quickly on that. Sorry, I didn't quite answer your question. Claire, don't know much better than I was going to do. The only thing I would say is when you talk to, to some of the secondary care consultants sort of around POW, they've said exactly what they were saying here. So we need to be supporting more out there rather than bringing everyone into POW, which will be managing the patients closer to home. We get into that. So there's very much a clinical view to support that as well.
Thank you. That's the point I was trying to get to.
Sorry.
But if I move on, can I just say I think that there's two things for us to reflect on beyond today's discussion, and one of them is relating very specifically to some things that have been raised by Sarah Evans, MS, and that's in relation to the engagement plan. And I think that what we will need as a board, subject to today's discussion decision, is for an engagement plan to come back to the board by the next time the board meets in July. I know that work has been done. There is consideration having given to what that engagement plan looks like. I would like the board to have the engagement plan back here for July. I also think, Claire, it would be useful to have a timescale as to when the plan for the community beds element can come back to the board as well. And I'm really conscious that you're doing a large piece of work with senior officials in Bridgend County Borough Council and the leadership of Bridgend Council to establish what that pattern of community beds needs to look like.
Yeah, so I think there's two parts to that, Jared. That one for next time, which is around around community beds and BCBC. The bigger piece, I won't say now, but we'll take point that needs to come back in.
Yeah, sure, absolutely. Okay, I've got a list of people. I'm going to Howell next, and then to Dillis. Thank you.
So I think the engagement element's been covered off, so I won't necessarily go into that again. Other than to say, I think there are ways we can be really creative about how we engage with our communities in a traditionally health organisations invite people along to sessions, don't they? That doesn't really work if you want to engage across a community. So being really creative and creating a bit of a blueprint, if you like, for how we might communicate across our health board patch, where communities are actually quite similar to the one in my state. So I think there's a real partnership value. Beds, I think, has already been covered as well. And I guess the third element to the two you just mentioned is the plan for the hospital site itself, which you mentioned earlier, Paul, which having as you know, grown up a few hundred yards away from it, I feel quite strongly about as well. So I'll look forward to that discussion as well. However, I think just back to Mace's point earlier, we have to remember this is a significant investment in my stake in the Shinby Valley itself, an area that has not had an awful lot of investment over the last 40 years, and as Reece alluded to, has had things taken away from it, and also health services in my stake, which will have a significant benefit both in the immediate term and in the future. And I think as well, the location and the transport, I don't think people perhaps quite realise how tricky it is to get to the current My Stake Hospital site, either by transport and even worse on foot, for what is an ageing population, and also the service provision and the impact that that could have. So I just wanted to support those elements and the positive nature of what that will provide for My Stake in the future.
Thanks, Mark. Dilys, thank you.
Yeah, similar to Howell, I think we really need to spread the positive messages. The statistics that Philip just gave us were very stark. And if I lived in that community, I want to know what you're going to do to improve that. In respect of the engagement, I know that you've already been involved in the third sector, but there are trusted people within the third sector, within the community, and who better than to advise us how we can access that community. As Howard said, it's not necessarily a meeting. It could be anything at a briefing in one of their meetings, or even getting the trusted people within the community to pass the message on as well. So I think the third sector are a really important part of this engagement process.
Yeah, thanks to this. Karen.
Yeah, following on from that, really, the word trust seems to have come up a lot today, and I think you talked an awful lot about engagement, but I think however you do it, there's that underlying lack of trust and cynicism about, we've heard it all before, we always lose things, blah, blah, blah. It's really difficult to overcome that, and I think that is, as you say, about building the right relationships, about demonstrating, about saying there are some red lines, we're not going to take these things out once we've said we've done it. I also think political support could help here, because the problem is it all changes, the focus, the priorities change on a fairly short-term basis, don't they? And sometimes we're
we're hamstrung by that. So I think that sort of level of political support would also be really helpful. But I think the point about trust is a thing we really, really need to work on, because to me the case is very, very well made. It's a huge investment, massive improvement, but that message is obviously clouded by this underlying lack of trust, which we need to address, I think.
Thanks, Alan. Before I come to Gethin and to Helen, to say that on Thursday of last week, I did email the 6 members of the Senedd representing the constituency in which my Steg and the Findlay Valley sits, with a detailed briefing note. So a week in advance of this meeting, I sent the same briefing note to the leadership of all of the council groups in the local authority, asking them to send that out to their colleagues, just to bring people up to speed. But there is a commitment to engaging in that political space as well, because obviously, although health is not devolved to local government, there is a clear interest from the local authority in terms of community beds, but also as a partner in helping to deliver an integrated care system using the ICRF resources to deliver that. But clearly, Senedd members, certainly for that constituency, with the exception of Hugh Ranker Davis, they're all brand new. So we will want to build a working relationship with them to take them along on this journey and to engage them in supporting that consultation process. So I think it's really, really important. I can to Gethin and then to Helen. Thank you. Thanks, Gav.
Yeah, no, thank you, and thanks for the presentation, Dale. Really, really helpful. I guess there's 2 questions for me that I think would be helpful if you could confirm. I guess the first is surrounding the rules of the IRCF. So I'm conscious that the IRCF there's quite clear criteria against which, and I think it would be helpful just to confirm what those are, what can and what can't be included in that, and recognise that they were rules established by the previous government, not the rules that have been established by health boards. And I think the understanding of the complexity of capital allocation within Wales is quite complex in this matter. And I suppose the other question that I to consider is, and if we don't make a decision today, what happens to our place in that programme? I'm conscious that the capital programme in Wales is significantly oversubscribed, and what is the risks associated with that if we weren't able to make a decision today?
That's right. Dale?
If I split that, then I'll take point 1 and ask Caroline to address capital. So in terms of IRCF funding, it's IRCF Priority 1, which is the development of health and wellbeing centres. Previous government had an aim to create 50 health and wellbeing centres across Wales. There's certain criteria around town centre first, meet decarbonisation, the delivery of integrated services are what's covered. It's for each health board and each service to determine how that is best delivered. I would say the capital allocation that we have is not too dissimilar to the schemes that we've seen being built elsewhere in Wales. But it's all in the pack in terms of priorities and what the objectives are. And that's what we've had to make sure we fulfilled as part of the offer that we put forward, including the original offer to Welsh Government and why we went to take the scheme forward, as well as they're tracking that through to the offers that went to you today. In terms of capital, I'll ask Caroline to
So in terms of we don't make a decision today, obviously that will delay the scheme. We have funding available this financial year to develop a business case. We need to get that in at the end of this financial year. And we would need to request, which is not guaranteed, then a shift of those funds. But ultimately a delay will cause increased costs, as Paul mentioned earlier. So increasing fees initially, but definitely an increase in the build cost depending on how long we.
Thank you. Sally, thank you.
And I think the other point is that, as Gethin alluded to, the capital pot in Wales is heavily oversubscribed. At the point at which IRCF became our focus in terms of this development, we had submitted a 10-year capital ask into Welsh Government, and at that point the confirmation against the All Wales capital pot was that only 2 of our schemes would be prioritised. Those at the time were the PCH ground first floor scheme and Llantrwst and Health Park. Subsequently, due to the roof issues, there was a another scheme introduced, which was, of course, was Princess Wales in Bridgend, which where significant expenditure was incurred as well. But we were very much guided that those were the schemes that would be supported in certainly the sort of 2 to 5 year horizon at the time.
Thank you, Sally. Okay. Thanks, Liz. And Helen.
Thanks very much. It's clear there's support around this table for investment in Cymru Valley in the community, and it's clear that we recognise that we must not do this to the community. We need to listen, but there are very real reasons why we need to listen, which links to Paul's point and Catherine's point about accessing the funding. While being a Future Generations Act, we will need to demonstrate to the government when we submit final business cases that we have listened to the community and that we are designing this with the community. So there are very real reasons why we need to do what we need to do to make sure that we get the best outcome for those children that Philip mentioned who will live to be 100, so that we make sure that there is good facility for them going forward, and it's what the community wants. But there's a real statutory requirement for us to comply with to make sure that we access the money if we come to that decision today.
Thank you, Helen. Thank you. Okay. Are there any other comments or questions to the team? No. Okay. So the board is resolving firstly to note the compelling case for change and the significant health inequalities impacting residents of the Cymru Valley and surrounding communities. The board will note the outcome of the long list and the short list options appraisal, including the reasons for discounting certain service options. Item 3 is to ask the board to agree option 4, which is the Cymru Valley Integrated Health and Wellbeing Centre at Owenny Road as the preferred option for progression through the strategic outline case and outline business case process, and also to approve progression to the development of a full strategic outline case and outline business case in accordance with the 5-case model for subsequent consideration by the board and Welsh Government. Can I ask the board to approve both of those items together, please?
Yes.
Thank you all very much. Are there any objections? Any abstentions? No. Unanimous. Thank you all very much indeed. We are now going to take a break for around 10 minutes. If you can return at around 10:21 or 10:22, that'd be great. Thank you. Okay. Okay, welcome back. We'll now move on to item 3.2, which is the board assurance framework. I'm going to ask Gareth to present the update report, which has been endorsed by the executive leadership group on the 11th of May.
Yeah, thanks, Chair. As usual, this is a standard report on the board assurance framework we bring to each public board meeting. On this occasion, there are no substantive updates in respect of the strategic risks themselves. So no new risks have been added in this period, no risks will be closure, and there are no changes to the overall risk scores during this period either. Obviously, as always, underpinning the board assurance framework is the organisational risk register itself, and there have been a number of changes to those details. So in the paper today, supporting the overall board assurance framework is the detail against each of the strategic risks, and there are a number of updates for those which are highlighted in red. As an additional source of assurance to the board today, Chair can confirm that this board assurance framework was also considered by the Audit and Risk Assurance Committee on Tuesday, as well as being endorsed by executive earlier in the week. So just asking for the board to approve the updates which are outlined in the appendix and to confirm that they have the assurance they require this period. Thanks, Chair.
Thanks, Gareth. Are there any questions to Gareth on the update report or any comments? Patsy, thank you.
All I would say is this has come such a long way, and it clearly follows the strategic objectives now and the risks to not achieving it. So congratulations to everybody that supports this process.
Well, thanks, Patsy. And again, I think just to say thank you to all board members for the fact that we had spent time in a board development session looking at how we were capturing our risk, how we were explaining it, how we were demonstrating actions to mitigate the risk, but just to broaden that and deepen that understanding. So thank you, and thanks to the audit committee as well for the work they do around this. So can I ask the board just to approve the update report? Okay, thank you very much. We're going to move on to item 3.3, which is the integrated performance dashboard. And this is the first part. Just to say that there are exec colleagues, so I'll call on first to present their items on the performance section. And at the end of all of that, I'll then come back to the board for any comments or questions. So I'll come to Claire first. Thank you, Claire.
Yeah, thanks, Chair. And a reminder that the integrated performance report is going through an evolution. So we are in the workshop that we are building those approaches in. A reminder that the full detail against quadruple aim and benchmarking of our services is in the appendices, and that the summary focuses on our access performance, quality and safety indicators, prevention and outcomes, and workforce. So it's important to say, isn't it, in relation to access, that we haven't reported in public since the end of March, and so we should recognise the significant achievement in terms of 0 over 52-week waiters. Only those patients affected by the bone cement issue waiting over 104 weeks, of which the 98, and achievement of our planned 0 over 8-week diagnostic patients, with the exception of neurocentric ultrasound. The position here for April shows some deteriorations, with 636 patients waiting over 52 weeks, 464 waiting over 104 weeks, and 601 waiting over 8 weeks for diagnostic treatment. In cancer, our performance remains stable and good in comparison to the rest of Wales, at 65% achievement within 62 days. And similarly, in urgent care, handovers within 45 minutes are largely static to last month, but improved by over 1,000 patients from this time last year. 12-hour waits static to last month, but a deterioration, and I know that there's a lot of work going on in terms of that addressing the 12-hour waits in ED. really important to say that package of care delays are at their lowest point for 3 years. So 189 package of care delays, but that shows a real trend of improvement. Still a lot of these too many and not where we want to be, but important to recognise. On mental health, our assessments and interventions continue to report a deteriorated position, with the recovery actions plan not yet impacting. And we anticipated and knew that this was coming in relation to changes in reporting and administrative processes. But we want to see that being restored. In terms of safety, 29 nationally reported incidents remain open over 90 days, and we're delivering below the target for complaints within 30 working days. But important to note that with the implementation of the listening to people framework in place, putting things right, that may result in some deterioration against that target, but we'll be aware of the future months. In relation to public health measures, those haven't moved since the last data point, so nothing to update on there. Sickness remains higher than we need it to be at 7.47% rolling 12-month, and appraisal generally improving at 70%, slight dip from last month. But I'll pause there and back to us.
Thank you, Claire. Much appreciated. I'm going to hand over to just to get in next on the operational performance section, and then after I will hand over to Richard. Thank you.
Thank you, Chair, and thanks, Claire. And just the numbers that Claire narrated in the proposed report is unvalidated data, and the way in which the timings are pulled for the data that comes through into the IPR is the unvalidated position. The 104-week validated position is actually 390 cases. They are in orthopedics, and there are a handful of neurology patients, which I'll come back to explain why now. And in 52 weeks, the position was 334 patients over 52 weeks at the end of April. All of those, bar 12, were in neurology. 12, the remaining 12 were some specialist orthopedic outpatients, and we lost the surgeon who was due to see those patients. Unfortunately, had to take some very short notice compassionate leave, and because of the specialist nature of the appointments, another surgeon wasn't able to see those patients. So they sadly were breached, but have been seen. Just in terms of neurology, so historically for the Health Board, our neurology waiting list has been reported at Cardiff, and the services provided to us from Cardiff under an SLA, and they historically have held the waiting list. As part of an agreement that we reached at the beginning of last year, we agreed that we would be transferring the waiting list to us. The waiting list is significantly lower at the point of transfer than it was last year, and we've got clear work to eradicate all 104 waiters in neurology by the end of July, and that we will, by the end of the financial year, have eradicated all 52-week waiters in neurology. We have appointed our first neurologist to the Health Board, which is a great appointment, predominantly focused on liaison neurology, so supporting our inpatients with neurological conditions, but Charlotte will be also taking some outpatient activity, and as part of that, we'll be looking at what our longer term model is for neurology. Just in terms of cancer, again, we for 7 months, 6 months out of 7, we have been the top performing Health Board in Wales for cancer performance, which is really positive. We are not at the 75%, which is where we are working to get to this coming year. But it is really reassuring, the consistency now in terms of our cancer performance that we've not had previously. So massive thanks to the whole team for the work they've done there. In terms of urgent and emergency care, just clearly 12-hour performance is the area of our significant focus this year, and seeking to significantly reduce the number of patients who have an extended stay in our emergency department. So there's a lot of work going on. We have also, as part of that, had some visits to other emergency departments. So most recently, a team came down to St George's Hospital in Tooting to look at their model and how they operate. A much larger emergency department than any of the three in CTM. Probably they see the same number of patients in one that we see across three. But again, some really good learning from there around how we could around different pathways and different approaches. But equally, they're really keen to learn from us around the navigation hub. There is a very, very early stage in their evolution, so a really good sharing session with the team at St George's. So again, that continues. I don't intend to pick up anything else, but happy to take any questions at the end.
Thanks, Kate. Before we come to questions, I will deal with the quality section of the report. First, Richie, I'll come to you. Thank you.
Thanks very much, Chair. Yeah, so just really drawing upon what Claire's summary was around quality. So absolutely, the data reflects the number of NRIs. It's for me to say that at this stage that actually we are now below 20 in that number. So a lot of work has gone in relation to those nationally reportable incidents over 90 days. And the concerns responses within 30 working days remain stable as well. Absolutely, we were right to draw upon a change of approach around our engagement in terms of moving away from PTR to listening to people. We are in the transition phase at the moment around that, but the teams are focused and have done a full engagement across the health board as to what this means at a practical level for all of our staff and teams. So that work will progress. We are coming to the point by which we are seeking to close the cases that we're dealing with under the PTR framework, and then we'll be fully engaged from July onwards in terms of the listening to people and that new monitoring approach. I think the thing I would like to point out at this stage as well around that is listening to people, and the framework that's been devised gives us further opportunity to use a qualitative narrative around the views of those accessing our services. And that's what we're seeking to do in some of the changes we're making within the structures, and realigning some posts around that as well to maximise on hearing the voices of our patients and families. I think really that's all I want to talk to on there, but happy to take any other additional questions against other quality metrics.
Thanks, Richie. I'll come, before we finish the quality section of the report, I'll come to Dom and then to Lauren. Thank you.
Yeah, thanks. I'll try and keep this very brief on there. You've got the data in front of you. So I'm just sort of speaking about mortality. Again, the analysis that we're doing at the moment is really good. What we managed to do is identify certain areas that actually in themselves are small numbers, but we need to look at everything, obviously. But are those small numbers, is that actually a concern, or is this actually just a variation because they have a cluster of cases? And that's giving us a real opportunity to dig into some of those particular areas. One area in particular we're working on at the moment, and it leads very much with what Gethin was saying a minute ago, is that we know there's a strong association between morbidity and mortality with length of stay in the emergency department. And that's length of time you see a doctor, length of time you get to a specialist ward. In particular, look at that, is that having an impact or not, and how's that following through? So that's probably our main focus at the moment. And then, of course, we'll move around other areas. But we've highlighted 2 or 3 other areas which the care groups are looking into specifically. So what I'm going to do at some point, I've promised you we will start bringing you that data in a slightly different way, so you can see it more, but maybe in a board development session it's pretty easier to work that through in a bit more detail so you understand how we're doing it and share some things with you there. But good progress has been made in that area, just to assure you.
Thank you. So just some additional bits of narrative to add to the data that's in your slides. So you'll see that the radiology information system was launched in March, so a huge amount of work from all of the team involved to deliver that to plan, and they're still working through some post-implementation challenges. You'll also see there's some reference to the sonography workforce and ultrasound. So it's a UK-wide challenge in terms of that workforce. So we've got some national conversations happening to look at that. But there's also some work being done locally to look at how the service runs, so realigning the support workforce. And we're also continuing to work with National Imaging Academy Wales, who are running training lists. So that helps because it's our CTM patients that are seen, but it also supports the future pipeline of sonographers in the area. With regards to audiology, there's some challenges with the adult waiting lists. So there's a service focus particularly on the adult waiting lists over the summer months. So they're going to pause non-essential tasks as well as focusing on review what the service model is to minimise appointment cancellations and missed appointments as well. Psychological therapies, again, is a challenge within our mental health services. So we've got no one waiting over 52 weeks now for a wide range of the services. And in our adult mental health community mental health teams, we're seeing their best performance in 6 years, but there is still work to do. So we are seeing the benefits of the work that the team are doing to review how the services run. Our local primary mental health services remain a challenge, so the waiting list validation is ongoing. We've got lots of groups running to maximise the number of people that we can see and offer input to. And there as well, there's work to reduce cancellations and missed appointments, but you'll see in the data that there's some improvement there for the third month on the run, which is positive to note.
Thank you, Laura. Before I move on to the workforce section of the report, Philip, was there anything you wanted to reflect on in terms of the public health data?
Yeah, just as Claire said, because of the nature of how often public health data gets refreshed, there isn't an update within the data. However, the interventions to ensure adequate uptake of vaccinations and increase rates of attempted smoking quits are ongoing. As Claire notes, the IPR is under review, and we'll be developing a timetable to reflect national data releases for public health. I've already mentioned the child measurement programme. I just want to say as well that the Welsh Index of Multiple Deprivation has also been refreshed, and I'll circulate the slide set that my team's put together for both of those releases, and I'll arrange for a board briefing at a later date. Thanks for
Really helpful. Yeah, so welcome back. Thank you, Philip. Paul, on this before?
Yes, just on the performance data, I guess I was just going to highlight with the NHS Leadership Board this week on Tuesday, which is the first one obviously since the new government. You will have noted already the focus that the new government have on waiting times, particularly. So I guess there's going to be no let-up in the focus, obviously, on making sure that we continue to improve our performance in waiting times. I think the recognition, obviously, that we've done some really great things that have brought us to a really good place now. I think there is a real opportunity now to sort of move it up a level, and Gavin and I have already had some conversations, not just about what we can do within the CTM, but also how we can work with our neighbours, because there is, and we had a useful conversation as chief execs after the meeting about how there's a greater opportunity, I think, to think about where we might be able to share pain, if you like, between different organisations, where maybe one organisation's got a problem in one area and another organisation has the less of an issue. Should we be looking more at mutual aid opportunities between us to try and help bring everyone up? Because there's no good one organisation succeeding if others are still struggling. So there's a real opportunity, I think, for us to think about how we do that. But I guess just to say, the focus on waiting times, I think it's going to become even more significant, because the drive with the message we had on Tuesday was very much, this is a government that wants to see things happen at pace and quickly. So I think we will be tasked to very quickly come up with some plans to further improve our performance in this area. So, I think we've done really well to get to where we are now. I think last year's been a massive achievement. The challenge for us now is to make sure that we continue that progress and we don't let, and actually I know we're not, but the risk is that things slide, and that's the concern, I think, in government, is that the performance that's been achieved this year drifts as we begin the new year. So I just think that all the things that Gavin talked about, I think, are really encouraging in terms of our next steps for our improvement in this area.
Great, thank you, Paul. Howell, on the workforce section of the report, thank you.
Yeah, thanks. The only thing I wanted to touch on was sickness. So if you look at the graph on page 19 of the report, so as we know, we kicked off a fairly significant programme of work in October to attempt to bring our sickness rates down from historical high levels. Hopefully there we're reporting it in sort of 3 different ways on the same graph, but I'll just try and explain that. So there is a sort of trend line in the background there that's so faint you can't see it, but we've had 3 months now of reduction in sickness in month rates. That isn't tracking through on the rolling 12-month rate because the rates remain above the equivalent rate last year. So that's why you won't necessarily see the corresponding in-month bringing down. What we need to do is bring it below. But if you look at March 2026, it is, however, dropping just below the trend line on the rolling 12-month rate. However, with sickness, it's dynamic. So there are lots of reasons why sickness comes down, not all to do with managing sickness. Oddly enough, it's not a rigid thing. So sometimes seasonal variation, lots of other factors. So I guess my message is, while I'm pleased at 3 months in-month reduction in sickness, it's far too early to tell whether the actions we're taking on the rate are having an impact. They are having an impact, though, on the things we know are evidence-based to contribute towards a reduction in sickness absence, which is positive. So the things we're able to control and the things we're able to manage effectively are being managed more effectively. But we've just got to wait, I think, and be patient to see if that transfers to a reduction in sickness rates. I would also say that sickness rates across Wales and indeed in England and indeed in other sectors have settled above pre-COVID levels. So understanding that dynamic is something we're continuing to try to do. And obviously the staff survey element that will come on to later on and how the experience work is a significant part of what contributes to this as well. So I'll come on to that a little bit later on, but I think we're just keeping on with what we're doing. The performance arrangements with the care groups have been really effective, and we're continuing those through the performance reviews in May and June, and we'll continue to track the sickness rates and report on those through here and in more detail at ODC.
Thank you, Hal. Much appreciated. Okay. Some good updates there from colleagues and quite a significant amount of data in front of the board this morning. Questions or comments? Patsy, thank you.
Yeah, probably my favourite topic again, the ambulance waits, the unscheduled care and acute medicine group. The such a clear improvement in the handovers for best part of a year now, but there's a clear correlation. I know correlation doesn't mean causation, but there is a very clear correlation between those patients spending less than 4 hours in A&E. And we're not seeing a huge improvement, or we're not seeing hardly any improvement other than in Merthyr Tydfil for the purple calls. We're not seeing the improvements in the performance for our resident population. And at some point, we have got to get there, because it's our patients that are sitting in ED waiting an awful lot longer, and they're not, those critically ill people are not seeing the benefit. The other thing I don't see on here, and I'm hoping it's because it's always 100%, is the red releases. Probably not called red releases anymore, but we don't see that. And is that because it's a good thing?
Thanks, Patsy. I'll bring Gethin and then Claire in on this if I can.
So if I perhaps pick up the ED performance and the response, the red release requests, and perhaps Claire will pick up on the conversations with JCC on the WAS data. So it's interesting. There has been the pattern we've seen around improved handover and extended waits in ED. This pattern has been seen across the whole UK. And part of that is that we are having to make decisions on who to move in order to, so rather than taking people out on a chronological basis, we're having to take people out depending on where they are in the department in order to come to flow. Recognising that the majority of our ambulance conveyed patients are normally poor mobility. They are our older, frailer cohort, because the vast majority of patients otherwise self-present. we need trolley spaces in order to hand those patients over. So what we're seeing is a slight disproportionate waiting time for those patients who are in ambulatory areas versus the trolleyed areas. Now that's not right, and so part of the work we're doing that you won't see in this data, but happy to bring something to agency in perhaps is what we're moving the bell curve of our distribution of waiting times to the left. So we've now got a zero tolerance at this point, and we're moving that continually to the left to reduce the extreme wait times that some patients have sadly experienced. So that work is going on. In terms of the red release question, it is because we haven't applied red release now for some significant time, and in fact, because of our improved handovers, we are seeing only 1 to 2 immediate release requests per week from WAS, because we're handing over crews in such a timely way. So that has gone. Hand over to Claire for the question.
Yeah, thanks. So Patsy, hopefully you saw the briefing that I said that was circulated in terms of the relationship between community response time and handover improvements, which is, isn't like, it's not linear, is it? And I think what we need to do is to continue to work through JCC with Weston on the exec sponsor programme of work, looking at how Weston managed by JCC this year. So I hope to be able to be helpful in that space. I guess I would just push back a bit in terms of we need to see that for our patients. I think what we need to see is everybody achieving the handover standards and WASC improving their response times, because for the reason Paul articulated earlier, it's no good if we're doing something for CTM. I completely agree that we want to get those responses.
So that is right. Some of our challenges, I think, when I've had a conversation with JCC about this, they said, of course, you've done really well, but if your neighbours aren't handing over quick enough, your ambulances are being diverted off to help sort problems in somewhere else. So we've got to get everybody into a place where they can release their ambulances.
And the most important thing is that the most critically ill patients, wherever they live, are being able to be responded to quickly.
Yeah. So, but I think, to your point, Patsy, and I've had some conversations with ambulance trusts about this as well, there are some underlying challenges in the ambulance provision in our PAT that have been there for a long time, not just about response, but also conveyance. We have some of the highest conveyance rates in Wales, and we have done forever and a day. And no matter how many times we have conversations about it, we don't seem to be able to get underneath why. So I think we do need to, on an operational level, and I think, to be fair, I've had a chat with the new chief executive of the ambulance service about this, and I think there's a greater degree of wanting to work collaboratively with us locally, operationally, because we've done some really fantastic stuff to try and divert people away from hospitals where they don't need to be. The navigation hub is being held up nationally as an example of good practice, and it's doing some fantastic work and could do even more. But it's no good us having that if the ambulance crews don't then use it and divert people through that to try and avoid people going in unnecessarily. So I think there's several strands, I guess, solving this challenge. Local operational improvement, commissioning influence through Claire and the JCC, and then also what the ambulance trust themselves are doing in terms of organising their own sort of operational processes. So yeah, I think we are on it, because understandably we were asking the same question when we're looking at the data, saying, well, where's the improvement in the response time?
It is frustratingly difficult to get the assurance through the hosted body audit committee on the commissioning of ambulance services, and no matter how much we push, we are not getting to a point where we're getting assurance that the commissioning is as effective as it could be, which of course then would
and I think the bit of work that Claire is working on with the JCC has been thought about, because that perspective has been shared from a number of health boards, and there's been a conversation between the health board chief execs about how do we get better at commissioning the ambulance service to be the service that we want it to be for the future. I would also say we've got new JCC chief commissioner starting, who has a very strong background in commissioning, coming from London, who I think will also be used to a more structured commissioning arrangement maybe. So I think there will be an opportunity there to to do that. And, but it's still also about working in partnership. Now, this isn't about moving it into a very contractual relationship. It's about saying what we're spending this money and how do we make sure that money is being spent to get the best outcomes for our population.
Thanks. Rachel?
Yeah, thanks, Chair. In relation to the package of care delays, which is improved, is a intelligent picture. I'm just interested in the story behind that. Do we know how we've achieved that improvement? Is it because of work? We invested quite a lot in stay well at home and also the services. I'm just interested to know if this is the result of a decision we made earlier.
So in part, yes. So I think that there's a couple of pieces. The first is we've got our data has got so much better. So our process for capturing the data, capturing people's delay codes, understanding that piece, I think we would say, so I'd probably far more confidence in the quality of the data than we probably had 12 months ago, and that is part of it. Undoubtedly, we've seen a reduction in the P1 cohort because of hospital at home, but also because of the changes that some of the local authorities have made to their service model. So particularly in RCT, where they've got they've worked very collaboratively with us in terms of a straight to service model, and we have seen the waiting time from for patients going out on a P1 significantly reduced, which again has reduced those volumes. And there's been other initiatives around some of those other cohorts. Pathway 3s remain a real challenge for us. So pathway 3s are patients who are awaiting complex placement, and it links back to something Claire said when we were talking about my STEG paper around work with the RPB, looking at what is the capacity plan required for our patch around nursing home placements, particularly those where they are needing specialist dementia placements. So those patients do have a very long time. We are doing a piece of work this year as part of the value and efficiency programme that is, so we have quite a significant cohort of beds utilised within the health board for patients who are admitted from a care home and go back to a care home. Now, it might be they go back to a different level of care. They might go from residential to nursing or from nursing to specialist. But for a lot of those patients, there is, when you look at the data, there's very little that we do medically for those patients. And so part of the model we're looking to establish this year as part of the V&E programme is having a team that holds that patient in their care, in their current location, and manages their transition to the next appropriate location, rather than bringing the patient into the general hospital with all the risks associated with that of deconditioning, hospital-acquired infection, and all of those matters, and that we can manage that patient in a different way. We use probably each year around 280 of our 1,000 beds are used by patients who are coming from and going back to a care home location. So there's a real opportunity to think differently about that model, and they will no doubt be adding to that cohort.
Thank you, Rachel. Kath?
Yeah, thank you. Yeah, I wanted to just ask, I know it's touched upon the adult mental health services. When I look on page 13 at the top two graphs around percentage of assessments undertaken in the 28 days and also the therapeutic intervention. I mean, the graphs are showing quite a dramatic decrease, aren't they? Are we expecting that to increase over April then? We're not expecting it to go down any further. That's one question. And the other question was, how long are the people waiting who aren't picked up within the 28 days? Are there other people waiting? Because I know there's a reference to I think a two years prioritisation of longest waiting patients. No patients will wait over 2 years by the end of April. Still an awful long wait, isn't it? Yeah. For that kind of intervention.
So in terms of the first question, which is the part one performance. So that has been driven by a number of issues that, as Claire said, we were aware that there was going to be this deterioration. The care group has got really clear plans of how they will get back to the level of performance that we would be expecting at 80% plus. So I'm happy to share that trajectory, perhaps through ODC, and that people have got that clarity. The other piece around the psychological therapies, which is where the reference of the 2 years comes from, is that we've been looking at the current distribution. So we know that for the vast majority of our services, nobody's waiting over a year, but there are one or two very small pockets where there are some patients who are waiting over a year. What we're really clear on, as per all elective access targets, priority number one is nobody over 104 weeks. That is still far too long for psychological therapy, and so it is, how do we get down to 52 weeks, and how do we get it down further? And again, there's a clear plan that the care group have that sets that out, so we can bring that again through ODC.
Thank you very much. And in terms of those over 2 years, it's the team is literally 2 or 3.
Okay, so small numbers, because I didn't get the scale in terms of no, but that's really useful to know. Thank you.
Thanks, Lauren. Any other, I've got a couple of questions to raise, but any other questions or comments from board members? If I could just return back to our ED performance, and in particular the 12-hour wait, which I know is particularly challenging for us. We've said in the report that we are exploring SDEC first model for GP referrals. I'm just wondering if you could just sort of flesh it out a bit as to potentially what that could look like, and where we were in considering perhaps some alternative ways of working that may actually improve, I suppose, improve or alter the numbers of people who might end up at our front door.
Yeah, no, absolutely. Thanks, Chair. So the principle is that we have 2 emergency flows. So we have patients that come in either by self-presentation or by Treble 9 ambulance, or we have patients that are referred in via our GP colleagues. And at the moment we have a bit of a messy pathway. So particularly out of hours, but equally at times, if we think a patient has a high likelihood of admission, those patients are managed through our emergency departments, and therefore have a long wait if they then need to be admitted. The evidence nationally and UK wide is that managing those patients through a same-day emergency care pathway changes both the management approach of those patients, because people are seeing them in the principle of I'm seeing you to discharge you, rather than I'm seeing you to admit you. And as we see with a whole raft of different areas where you see a patient, the environment, all of those things have an impact on clinical decision making. Clearly, those that need to be admitted will be admitted. But we have invested heavily in our SDEC provision within the health board. We've built a fantastic new same-day emergency care area in Prince Charles. We've just reconfigured the footprint at Princess of Wales. We have a really good unit here at Lord Glamorgan. And so part of that is moving is that all GP take will go through same-day emergency care. The other bit of the development that we are just finalising as well is that we will be putting an acute medic into the navigation hub. So we will be trying to standardise our approach. So rather than each GP having to ring their local site and what have you, we'll be putting the acute medicine service through the navigation hub, so that if the decision is that the patient doesn't need admission but needs some community nursing support or would benefit from an OT assessment, because actually we're thinking borderline social admission type of piece, that the resources in the navigation hub wrapped around the acute medic will allow us to have a greater range of interventions. So at the moment we end up doing that once the patient's in hospital, and of course keeping the patient at home needs to be the first option. So all of that is a fundamental part of that redesign. But there are a number of other pieces that again we can bring more detail to board on.
Thank you, Ethan. And I really appreciate the fact that, you know, as we at some point in this year publish our case for change, being able to explain the ambition around what, you know, urgent and emergency care looks like is really important. And Claire and I we spent 3 hours yesterday interviewing candidates who were applying to be ED consultants in our health board, and you know, the presentations were around, you know, the safety, the quality of care, particularly where we have large numbers of people waiting a long time in our emergency department. So it was, again, I think just, you know, this is an area of activity for the NHS where there is significant risk, obviously, to patient safety. But obviously the model is something that needs to be worked through. And I think, you know, these sorts of innovations, particularly around the NAV hub, at least with that, I think it would be very interesting to see how we gather data that shows what some of the challenges are, what are the reasons for which a GP might be making a referral to A&E, and you know, it allows us to map more effectively then some of those demand issues. I've got another question on delayed pathways of care. Welcome to Don first, but I'll move on.
Can I just sort of so just reassurance, normally I do have a GP sitting next to me who might get me if I get this slightly wrong. But there's been a lot of anxiety amongst certain clusters about how we use this model for the navigation hub, and we have some very passionate GPs leading it, which is really helping to get that message across. There's been a lot of work going on with a group medical collaboration group I've been working to get the LMC to appreciate that we're trying to help, and this does not in no way block a GP from saying this patient must be seen in hospital. In my opinion, they need to be seen urgently. It helps, and it's more for those cases of one, helping them get those acuities, but more for that grey area of we can't manage this in the community, not quite sure where we go with it, and it's a real resource. And that's the key area that we'll really be driving into. It's a fantastic option. It's just getting everyone on board and understanding a new model of service, which I think we'll all benefit from.
Yeah. And I think it's a really important point, John, and I think also it responds, I mean, having been recently to a meeting with general GP colleagues, one of the frustrations around when they're trying to send in an admission, it's trying to find the right person to speak to on the phone, and they use phone switchboard and they get sent to the wrong person, and then they get bounced. They said you spend it. So in a way, what we're trying to do also is streamline it. So there's just one number, and you get straight through to the acute physician of the day, effectively, who will then have a chat with you about the patient, the situation you're dealing with, and may say entirely, yeah, bring them in. But the advantage is we can do it in a more planned way. So we can say, yeah, bring them in at, you know, we'll see them at 2 o'clock this afternoon. So hopefully the patient gets a better experience, because if they are coming in, they're coming in a planned way with a time, and they're expected, so that, you know, we can hopefully make that experience a more streamlined and pleasant experience for the patient, as well as hopefully improving the coordination of care with the GP. So
Sarah, yes, it's a more formal version of what I do informally with the AMU unit and the consultants on call. It's just that they're busy, and tracking them down and having that conversation with them is really difficult, and it's very similar to what happened with surgery when we put the first unit in. It just allowed us that direct communication. And I would just endorse what you say. Honestly, the change in the front door in terms of the telephony and switchboard is improving, I would say, but that has been very difficult, and there are times when actually it can take me 35 minutes to actually get to the point of being able to discuss with somebody, and if we can sort that out,
this will be a big step forward to be able
it's not about the
straight direct line through to a physician, and not having to go through any steps, just speak straight to the consultant.
I think that's the first 6 months of the medical collaboration group spent just talking on that issue.
I've been there.
If we move on, can I just turn very quickly to the delayed pathways of care data? And if we look at the acute data, it's now at its lowest level in terms of pathways of care delays for, well, certainly since the last 3 years, but it's the lowest level we've got in terms of that which we have in front of us. So it's now significant improvement in terms of reducing the number of people who are experiencing an acute delayed pathway of care, and the same really for community pathways of care as well. We took a decision some time ago to ring fence resources to employ healthcare support workers. Is this mostly because of those people at pathway level, at level 1?
Yes, it is.
And I think that it's really important to articulate that the decision that this board took, I think it was the summer before last, if my memory serves me correctly, to recruit more people who are healthcare support workers to help expand the hospital at home programme has now seen an improvement in the numbers of people who are able to leave more quickly than perhaps they were. So this is really quite a significant achievement, and it does demonstrate that the investment in the community, where so much work can be done, is essential to the overall system improvement that we see in our hospitals. I know there are challenges around pathway 2 and 3. And you've alerted the board to that in the report. I suppose the key question then is what next?
And just to be clear, it's pathway 3 that is. Pathway 2 are patients going on further rehabilitation. That there isn't significant issues with. That could be even quicker if the pathway 3 performance out of our community hospitals was sharper, because of course that enables us to get patients into rehabilitation more quickly.
Fantastic.
Yeah, it's just made me think. I mean, in terms of the data we have on this, I know it's all been looked at, but having the context around where we've come from and where we are now is really, really useful, because when you just read the paper, it feels quite stark in terms of where we are, trying to look at the target and where, and the actual. And I just wondered, I don't know, I know we're looking at it, aren't we, Claire, for SDC around longer term metrics. But if there was a little bit of narrative around some of these,
I also think
it would
something
be helpful.
about, we've got the annual report comes out in July time, which summarises, what we've achieved in the past 12 months. There's something about using that as an opportunity to say, at the beginning of the year last year we were here, this is where we are at the end of the year. We've made some, whether that's about waiting time performance, reducing the number of people with delays in hospital, increasing the number of people going through the NAV path as alternative to admission. So we could turn that into a nice sort of graphic type of thing to say, look at the progress we've made in the number of these areas, because I think it is, and and every one of these people is a real person who's had a better experience as a consequence. But it's a really good point.
I was thinking over maybe 3 years as well, though. Do you know what I mean? Slightly longer time frame.
Well, there's something, and I suppose it's probably something as Claire would say. Looking at the SDC type of sort of place, this is where we are now. This is where we were, and this is where we want to be in 3. So it's 3, 3, and 3, isn't it? It's like we've done really well. It's the old mountain analogy. We've got to the top of that mountain. Then we're in the middle of climbing the next one, and what's the one we go to beyond that? So I think it helps us set an ambition as well.
Thank you.
Thank you very much. Any other comments or questions on the report, on any of the sections? No. Okay. Thank you. I'm asking the board to note the report. Are colleagues happy to move on to the next item at 3.4, or would any be appreciated a break before we continue? Happy to continue? Yeah, this is the one item before we break at lunch. Okay. Item 3.4 is the specialist palliative care services, and I'm going to ask Gethin to present the report, which is before the board for approval. Thank you, Gethin.
Yeah, thank you, and good morning. So firstly, apologies from Dr. David Andrews, Medical Director of the Primary Community Services, who was keen to come and present this paper, but he's on annual leave. He split the country, celebrating a birthday with a 0 in it as well this week. So
just like you get.
Yes, but sadly a 0 below me. A decade below me, but never mind. So in terms of this, so board members will be aware that there have been significant challenges in the provision of resilient specialist palliative care services at Stockham Common for some time, driven by a lack of senior and middle grade medical cover, and there is a national shortage of palliative care physicians, but this has been particularly pronounced at the service that runs out of Stockham Common. So before you today is a paper requesting board approval to make permanent a temporary service change that was implemented in response to the shortage of the medical cover, which resulted in the cessation of the specialist And I will emphasise the word specialist palliative care services at the hospital, with those that were requiring the specialist input needing to be transferred to the Button Newydd at Royal Glamorgan and Princess of Wales for their care. Just in terms of a little context, so CTM has a comparatively high reliance on inpatient beds for the provision of specialist palliative care, which reduces, therefore, the ability to use that resource and that workforce flexibly to meet the demands of our population. And we know that many of our patients would like to die at home, and our ability to respond to that is compromised because of the focus of resource to deliver bed-based services. And in light of that challenge, as set out in the paper, a recommendation from the service was approved in February 25 by the Executive Management Board to consolidate the provision of specialist palliative care services to the units at Royal Glamorgan and to Princess of Wales. Just in terms of the specialist element, so this is for patients who need very, very specialist interventions and support, particularly around pain control, but also some other supports that need to ideally be provided on a site with acute services in order to be able to manage those patients safely and that range of intervention. They are beyond those that are provided by general physicians, be those GPs, be those general medics, for some very specialist interventions. And therefore the proposal that has been presented is that we consolidate to the two units, that we reinvest the full budget of Ward 6. So I just want to be clear, this isn't about taking money out of the system. This is about reinvesting the full budget of Ward 6 into a remodelled community specialist palliative care unit, which would run in as part of the whole hospital at home model that we've just been discussing the benefits of in terms of package care delays, that would allow us to have a hospice at home model. So we already contract with Marie Curie to provide social care support for end-of-life patients, and this would be enabling us, like we've done with Hospital at Home, to wrap around specialist resource, both medical and nursing, to support those patients without an expectation of reliance on the GP, because of course this is about us supporting those patients. But it will allow us to care for far more patients in our communities than those patients who wish to die at home to do so. It also will allow us to increase the amount of liaison capacity we've got going into the acute hospital, particularly Prince Charles, where again a number of patients will for clinical reasons need to remain there and that their service will allow those to be managed in that place. But equally, and the really important bit is that as part of this is we will continue to offer a direct admission model for general palliative end-of-life care into Ysbyty Cwm. So we will always have admitting beds within YCC to ensure that those patients that do wish to die in a hospital setting and whose needs can be met will continue to be able to access the service at YCC. As I say, this is genuinely about the specialist piece, and just to put that in context, so since February 25, we've admitted 786 patients into our specialist palliative care units for their end-of-life care, of which 37 were patients from the Merthyr Cynnon catchment. So the vast majority of patients who receive care at Ysbyty Cwm will continue to receive care, end-of-life care at Ysbyty Cwm. So we're talking about a very small number of patients, and I know, and we've got to consider that in the context of these are patients whose family are going to want to be with them. So it's not underestimating the impact on those families, but it is about supporting those families to get the best support, the patient to get the best care, and that we are able to provide that service. So it is important that we continue to offer that. As part of the engagement with our community, we've undertaken a 7-week engagement period that included a public event which SPICE were part of in Aberdare. We had dedicated website for this engagement piece. We've had a variety of briefings and presentations to a significant range of stakeholders as part of that. And on the back of the event in Aberdare, a decision supported with engagement with SPICE was that they're not to run a similar programme in Merthyr, because the feedback was very clear and categoric. End of life care is hugely emotive, isn't it? And understandably, the feedback from all of that engagement was that there was significant emotional response to that, which is completely understandable. The key, undoubtedly, there was a really strong desire from the feedback to keep specialist palliative care at YCC. There was a concern that the loss of SPC would mean that there'd be a loss of inpatient end-of-life care, and I think we're really clear the two are distinct and different, and our commitment to the continuation of general palliative end-of-life care on that site is absolutely clear. We did see an increasing understanding in our community about the model and how that would play through, and similar to perhaps some of the discussion we had regarding my stag, there was perhaps a limited confidence that the community model will be delivered and certainly delivered in a way that would be a truly replacing the inpatient provision. And of course, it won't completely replace the inpatient provision, because there are some patients who will need inpatient care for their intervention. But it is clear that we need to continue to communicate and share and engage with our community around those service changes, and that we continue. And I think the piece that is really clear is once we should board support this case today, that we really do proceed at pace with the provision of the community alternative, and that is going to be crucial to get that stepped up, and how we manage that transition phase is going to be crucial. I think we absolutely need to acknowledge that there was strong support from our community to retain SPC. As part of that process, though, there were no alternative proposals that enabled us to consider how we would do that, recognising that the driver for this change is the fact that we are unable to recruit senior medical staff to provide this service. So I think it is therefore really important that we acknowledge that, but there wasn't a suitable alternative there. So therefore I'm asking board to note the feedback from the community, and that was driven there, that we recognise that the current model is not sustainable in to provide the level of specialist palliative care that we would want for our community and our population, and that and to approve the proposed closure of the service at Ward 6 into a community-focused specialist palliative care model, operating under the auspices of our hospital at home.
Thank you, Gethin. Before I open it to board, if I can just bring Dom in at this point, thank you.
Yeah, it's just to support Gethin sort of points in there, is that currently our capacity can't demand, at least what the demand actually is. You know, it's a natural process there, something that we deal with all the time. Is how do we manage to make that as high a quality and a good debt as you possibly can? And those terms do apply very much in a debt. It's the impact on the individual themselves, but also on the family and the repercussions that comes afterwards. We medicalise death too much. I'm honest with you. We bring people in, we keep them in longer than we should do. If we can provide that support and care at home, but that doesn't mean leaving the support and care of the patient dying and the family having to then manage everything afterwards. It isn't. It's all the others doing it. Specialist care is absolutely unique. You need some incredibly well-trained people to be able to deliver that, and that is not what we would get on a normal hospital ward, on any other place. As Gethin said, I'm not going to list all the things they have to do, but it is far beyond anything that you would expect a normal doctor to be able to do, or a nurse to be able to do at the next time there. Which is a point as well, you know, Claire Turner, the CD, very supportive of this as well, has come through the palliative care team as well as anything else. They would love to be able to do that, everything to every patient, and wouldn't we all, but there's a reality of the resource that you've got. That maybe with this sort of model that we're doing, standardising and making it better, it will attract more people into working in our organisation, and that'll help improve what we can do. And the only thing I would just say that for me, the focus of getting into the community is important. The other focus that we have to think about is end of life care generally on our wards. How do we start cleaning up? Because at the moment we're relying a lot on palliative care teams coming in and supporting them on the wards. As Karen and I found when we went to visit, so both didn't we get here, they were talking about going out on their outreach. That is not what they're there for. We should be able to up-train our staff, the nurses and the doctors on the wards, to manage end of life in a much better way. So we don't. So then that was just real essential resource is used in the right area that it needs. So all I'm trying to do is add a little bit more detail to the fact that I completely support what the whole proposal is, and with your backing to it too.
Thank you, John. I'll come to Sarah, to Hayley, and then to Helen. Thank you, Sarah.
I was just going to say, liaison is really important. I've got a friend who's in a role in the Vale, providing education on the ward to try and freestand that expertise within the wards, because there's something that needs upskilling. I was just going to say, is that going to be reflected in support to the community? Because we provide a lot of end-of-life care, but what we rely on and value is liaison with specialist services in order to give us support and reassurance that we're doing the best thing for the patient. So just it's both sides of that boundary. And liaison is my point.
Yeah, absolutely. And this is all about creating that resource that enables us to have people that weren't able to work with primary care, with the clusters in that way, so that we can ensure that that general upskilling is there. Because you can't be a specialist unless everyone's working to a consistent generalist bar, and you know that's a really important.
Thank you. Hayley, thank you.
Thank you. And as I guess you guys have said, it's the staff that are going to looking after these patients, isn't it? The nursing, any kind of other AHPs that are going to be delivering us care. It's great that we've kind of engaged with the community, but the paper just didn't sort of mention about engaging with sort of staff or staff opinion.
Oh, there's been significant engagement with the work. This has been a proposal that has been developed by the service. So this has come from them as a group. Undoubtedly some of the staff on Ward 6 are unhappy about the proposed change, but lots of them are excited by it. So it's but it is a service change that has come from the service around answering the problem that they're saying they can't continue.
And just following on from that, I've been several times to Ward 6, and I know that the senior nursing team up at YCC have had lots of conversations with the team. Everyone's had one-to-one conversations about what this means for you on a personal level. Lots of them have seen an opportunity to go and do and develop their skills going out into the community and do it. But those that want to stay in YCC as a base are being found roles within YCC. So everybody within that team is being supported to make sure that the change is handled as carefully and sensitively as possible, recognising that they've all given a lot of time to the service, and it's that sense of loss of feeling of 18. But as Gethin said, if I think trying to re-energise people and saying, well, look, this is a real opportunity to take palliative care much more out into community settings now, enhancing, let's not forget we've got district nurses already doing great work in palliative care, we've got Marie Curie, all those sorts of organisations. This is about beefing up and enhancing our community-based offer, so that's getting so that we can really support more people to die in their place of choice.
Claire? It's just really important to say that is a single report in terms of the engagement feedback, which includes all the staff engagement as well, so it is themed, but it's not the totality.
Thanks. Helen, do you have your hand up? Yeah. You did.
Yes, I did. Yes, that's right. Thank you, Beth. And I thought I was really clear. I completely support the proposal. Just wondered what the proposal is for review going forward, and board seeking assurance that it does what it says on the tin, and that it is delivering what we all hope it will deliver. Thanks.
Yeah, no, that's a really good question, Helen, and allows us, in terms of our monitoring of that going forward, is looking at the number of admissions we have from that patch, that they're appropriate. So again, we run a single point of access model through for palliative, especially palliative care, so all referrals go through that, and they will then say, yes, that's a patient who needs our service, or they'll provide advice and guidance. So I think through that audit process, being clear, if we find a cohort of patients then whose needs are perhaps not being met in the way that we'd anticipated, then pulling that through. So we'll continue to monitor that, and we can bring some reports back. Again, I think it's important to stress this is a proposal that is evidence-based, is good national evidence, and as I say, is something that's being developed by the clinical team. So they've really looked at those patients, they've understood the patients, who they see, what they see, and how they can best meet those needs. So but you're right, we've got to have a check and balance.
Yeah, and it will be good to see the good news coming back here. So thank you.
Yeah, thanks. Richie, and then I'll come to Cass. Thank you.
Thanks very much. So I think absolutely we're having the right conversation here in relation to palliative care. It's right that we medicalise aspects that need to be medicalised, but actually there's a huge component here that's provided by families, carers, and nurses alike. And I think that separation is key, because otherwise we run the risk of overwhelming our palliative care physicians who are specialists in their field. And what we need to be doing is securing and safeguarding access to those that require that very specialist intervention. I think the other thing is as well, what's kind of being pulled into the conversation here around the broader context is absolutely the right thing. So we have a strategic group already set up looking at end-of-life care, which I'm chair. And as you would imagine, lots of these elements are picked up through that. So particularly around future care planning, integral part of this as well. Education and training. So across our ward areas, within the community settings, us as a board should have expectations that our teams, our clinical teams, will be able to provide palliative care up to a certain level. And absolutely, that's what we're setting out to do. So I would anticipate and expect that the monitoring that you're seeking as well should function through that strategic group going forward to support what we're describing here. So I think fundamentally, based on all the challenges that we're facing, the reason that the paper's been brought for consideration and the position that we find ourselves in, I think that we have to support this.
Yeah, thank you. Yeah, I think it was a really good paper, really clear. It was really good to see the engagement themes and issues coming out as well. So I think that was really good. And also recognising, I guess, the experience and commitment of staff. I think visited them myself as well. It's really committed staff there. So I think we should acknowledge that. I was going to ask the same question that Helen's already asked about what does success kind of look like and how do we know we've achieved it. I guess my other question though was around the 16 specialist palliative care beds we'll have left. How do we know that's going to be enough? Have you done any assessment on that? And could you just talk a little bit more about that?
By all means. So we, in for the last 16 months we've been running with 16 beds. We haven't been in a position where we've declined an admission. So we all the modelling that we've done suggests that the 16 beds should be more than adequate, and still leaves us in a reasonable, in a reasonably rich bed per head of population than the rest of the patch, and that modelling is, having lived it for the last 16 months, what we've not seen is positions where we've been unable to accommodate patients, and I think that's positive, and so at the moment I don't have any concerns that we'll be running capacity light. Equally, the provision of community-based specialist palliative care means that there will be patients who currently are in either of the above bins who will also benefit from that. So it should enable us to offer a more robust alternative across the whole of CTM, so that patients that currently are only able to be offered bed-based care across the patch will also be able to be offered home-based care, so that should reduce further the demand on beds. I think it's also worth noting that all special palliative care beds in CTM are NHS funded. You'll all see the media coverage of the pressure on charity funded hospice beds, in particularly over the bridge, and where there's real struggle in terms of those where they're having to pull back service. So I think this is in that context, this is about absolutely making sure that we continue that investment in our specialist palliative care service in the context UK-wide where there is a degradation of service.
Dom, specifically on this?
Yeah, it would be very remiss of me to not point this out to everyone around here that in terms of beds, we are doing very well compared with the rest of Wales. Compared with consultant per head of population of palliative care, we are one of the lowest across the UK as a health board, and we haven't made any changes because of that. That is just the reality. So the fact we out to recruit as much as we can into this area would help us even further to expand on that. But it's to do with the money. But the consultant body wouldn't let me off. They didn't point that out. It needs to be clear of just what the situation we're actually in, of course.
Thanks, Tom. Kathy, anything else? No. Oh, sorry, hang on, Kathy. No, Kathy. Yeah, Kathy sat next to me. Kathy, anything else?
No, that's fine.
I'll have a list. Hang on. Carolyn next, please. Then Patsy. Then Kathy.
Yeah, I think my points have all been covered. I just wanted to say I fully support this. I found the explanation of the difference between specialist and generalist palliative care very helpful in informing this. And given what we saw in the specialist areas, I think that need to upskill other staff because they were very pressured what they do going out. So I think my concerns have been covered and I'm fully supportive.
Thank you. Patsy?
Are we providing specialist end of life care to patients who are in nursing homes? Because that's a whole different cohort of people, and in my unfortunate experience is worse than woeful.
So I mean, I think there's a broader conversation here, Patsy, about how we support nursing homes generally in terms of upskilling and providing expertise in. Now, obviously, nursing homes, by the nature of their functions, have nurses working in them. There are people like district nurses are less present in a nursing home because the idea is they've got people in there. But as you rightly highlighted, often some of the challenges we pick up, whether that's through admissions into hospital or others, is that the skills and expertise of the nursing homes aren't always consistent. There's some excellent nursing homes out there, but there are some where maybe because of turnover of staff or experience of staff, it can be a bit limited. So there's a lot of work that we do already to try and work with nursing home matrons and others to bring up the skills, offer training in things like infection control and end of life care, medication management, all those sorts of things. So you really like to highlight it because many people, we talk about people dying in their own home. Well, for many people, that is a nursing home, and it's really important, therefore, that those staff have the right skills and expertise. And I think having more of our capacity out in community settings with palliative care expertise will enable us to do more of that sort of training and upskilling. So I hope that will bring up the skills of generally nursing home patients as well.
It is particularly the medication, the prescribing of pain relief in nursing homes that is a major issue.
And absolutely, so that's absolutely what we need to be doing with those plans. I think Sarah wants to follow up.
Yeah, I'll come to, I've got Kathy first, and I'll come to Sarah next. Thank you.
Yes, that was really helpful, thank you. Two of my questions have been answered. One was I wasn't quite clear about the sort of interface between moving to this new model in terms of stopping the old way of doing it and you know, getting the new way of doing it in place. And you know, but I think there's already, I think Helen asked, could we have some feedback on the implementation? So I think that probably covers.
I think what might be useful on that, I'm just wondering whether, in terms of the work of ODC, perhaps I know there's capacity build up that's required to implement from September. So obviously getting things in the right place for when closure officially takes place. But it may be as we lead up to that, as we lead up to that, and then beyond that, reflecting on how well it's working.
And of course, we've got to do no CP as part of that. So we've got to land that bit of the process in order then to be clear. So the once we have a decision today, should it be supported, then we're able to start that detailed engagement plan.
So
I was just going to make a comment in terms of bed availability and capacity, that of course we tend to think of people being admitted and dying in hospices, but quite often what they need is that people have a challenge at some point in their illness pathway which needs specialist intervention. The patient might be admitted or be managed at home in this new thing, and then they would get to a point where hopefully, for example, with an interventional pump or other kinds of pain relief, they might then be stepped back down again. So it is a very fluid process, was the point I was just going to make.
Any other comments or questions? No. So just to recap, we're being asked to agree to reduce the number of specialist palliative care inpatient units from 3 to 2. That does mean, it's really important to be clear on this point, that we will be retaining the Aberthin unit at the Royal Glamorgan Hospital and the Aberthin Newydd unit at the Princess of Wales Hospital. It does mean we will be closing the specialist palliative care inpatient unit at YCC. I think it is important to reiterate, and Gethin has made this point, that we are reinvesting more than £1 million of the resource from Ward 6 into remodelling a community-focused specialist palliative care service through the Hospital at Home scheme in Merthyr and Cynnon localities. So retaining that investment and reprofiling it locally to people's homes. In doing so, to mitigate the impact on Merthyr and Cynnon through a development of an enhanced community service for SPC in Merthyr and Cynnon Valley, I think is absolutely essential. And we will be strengthening the SPC liaison support in our acute hospitals. It also means the introduction of direct admissions from the community to ring-fenced general palliative and end-of-life beds in our community hospitals. So those are the recommendations that are being put to you this morning, and I would ask if the board would approve the progression to implementation, including the development and delivery of an organisational change process. Colleagues happy to support that recommendation? Yes. Thank you very much indeed.
Can I just say thank you, because I think this has been a long process of work, and there's been a huge amount of effort and time put in by the team in the primary and community care group to handle this very carefully and sensitively, given the emotive nature of the changes that are being proposed. And I don't think we should underestimate that the paper today is the product of a lot of engagement, conversation, thinking, hard work that got us to the point of being able to make this decision today. So I just suppose I should just place on record thanks to the care group team for leading this process, and also particularly Claire, the clinical director, who herself clinically led that process as well. So just I thought it was thanks. And
I think, Paul, in recognising that, it's not just the internal piece of work that was done to demonstrate to us that there was a new model that could be more effective, but the fact that our clinicians were keen to engage and lead those external conversations with elected members, our communities. I know that's really helpful when colleagues are willing to make the case, because it does yeah, they can describe things in a way that a lay member like me would not be able to describe. And I think, you know, having clinicians with the expertise willing to have those conversations is really valuable. I'm really grateful to them for having done that. We do have a little bit of time available to us for the moment. So what I'm proposing to do is just to move on with a couple of items before we finish for a break. So I'm going to move on to item 5, which is the governance and board business activity, and in particular the action log at 5.1 in presenting the action log, which is for noting there are a number of items proposed for closure, and those items listed are still open and proposed to be dealt with at our July meeting as well. Are there any questions on the action log? Yes, thank you, Patsy.
Yeah, just one. The top one, we both numbered 3.1, unfortunately. The top one, 3.1, listening and learning service stories, is proposed for closure, but further down under 3.1, page 4, again, it's a listening and learning story, is in progress. Where I don't get the consistency. The top one is saying we're going to be dealing with, not quite the right word, but dealing with the outcomes and the actions following the stories that we hear in an annual report effectively. Yet the one further down is suggesting it's still open and we're going to treat that one differently. I don't.
Gareth, you come in this? I'll bring Dom in then, perhaps.
Yeah, so I think the general approach is we will deal with it in the annual way, which I think we introduced last November when we met as a board and we looked at that. I think the specific one further down is to do with a specific issue, which we've kind of taken away and had a ring fence that.
Yeah, the second one you referenced, Patsy, is the particular patient story relating to transition of paediatrics to adults, whereas I think the one above was a generic. How are we handling all patient feedback summaries for the year? So I think that's probably why there's different feedback. And Dom's obviously
yes, exactly that. We took a specific action from that, not about the actual case, but about the service, and we will bring the service back to discuss with you at that point, rather than the actual individual's case. But so that's what we're doing.
Thank you, Dom. Any other questions on the action log? No. Obviously, we'll resolve to note the action log. Thank you very much. 5.2, matters arising not contained within the action log. Anything colleagues to raise beyond that? No. Thank you very much. I'm going to move on to item 5.3, the board committee and advisory group highlight reports. And I'll just move firstly to the Quality, Safety and Experience Committee of the 24th of March. And just to get Carolyn as chair of the committee to introduce this item. Thank you, Carolyn.
Yeah, thank you. I'll take the report as read. If you remember, because of the timings of these, I reported on this verbally at the last meeting, so I won't go through it again. Our next meeting, in fact, is on the 3rd of June, so I'll obviously report back next time. Happy to take any questions, but we did discuss it at the last meeting.
Yeah, thank you, Carolyn. I think Lauren, thank you.
Thank you. Just to say within that, there's reference to the R&D framework assessment that we submitted after that meeting. So it's a submission we have to do to Welsh Government in terms of our R&D strategy implementation, annual reporting, financial management, and adhering to the contract. So just to confirm that we've had confirmation from Welsh Government that we were compliant across all 4 areas. So that was a really good outcome, but a huge piece of work from the R&D team. So just to acknowledge that, thank you.
Yeah. Thank you very much. Any other comments? We're happy to note the report. Thank you. 5.3.2, the Operational Delivery Committee, and I'll ask Rachel to introduce this item as the chair of the committee. Thank you, Rachel.
Thank you, Chair. We've covered an awful lot of what was in the ODC agenda through the performance reporting earlier. I suppose just to draw your attention to some of the items that we wanted to escalate, in particular the digital and data highlight report, where we raised some significant concerns around the mental health electronic patient record procurement process, which has kind of stalled a little bit as a result of Welsh Government to changing their approach. So we just wanted to raise that it could potentially have cost implications if the process is delayed further. And then a positive escalation. in terms of the fantastic work actually that Stuart and his team have done on a number of different platforms and major systems that went live during the period, including the radiology upgrade, Badgernet, OpenEyes, and the EPMA system. So just to note our thanks to Stuart and the team for just an incredible amount of work completed. And there was also we wanted to raise the ambulance 12-hour emergency department weights, which I think we covered, and Claire has circulated an update on that, which hopefully members have received. I think we've covered that off. So I think it's with JCC to do a bit more investigation into the differentials. So we'll hear more about that hopefully going forward. Finally then, changes to gastro services. We noted the emergency service change relating to gastro services, and a briefing paper had been circulated to board members earlier on the decision taken. So they were the matters that were escalated. I also just wanted to note that we had some fantastic presentations from Howell's team on the workforce metrics, things like the NHS staff survey, employee relations annual report, and you know, it was evident that we are now perhaps triangulating or certainly making connections between, you know, the staff survey outcome and that had improved, and then we've been taking that survey up, it improved, and then the employee relations stuff linking with that workforce development plans, and how do we learn from each of those things to actually move things forward. So that was really interesting. Again, I think a note of thanks to Sally and her team for where we landed at the end of the year financially, notwithstanding that there are challenges ahead for the current financial year. But again, a phenomenal amount of work delivered through the capital programme, and so we wanted to make sure that work was acknowledged, and thank you, Sally, for that. There was the endorsement of the disposal of Pontypridd Cottage Hospital. We had some estate and energy performance updates, and that was pretty much it. Another heavy agenda. And in this meeting, I think Gethin has suggested at least 4 items that we take forward onto the next one. But just to say, you know, it's been mentioned earlier about the improvement in the reporting that we're getting, even just in the size of the papers. It's not that we're getting less, we're getting better quality information that we, you know, so and when we focus on what we're talking about. So thank you to Claire, to Gethin, to everybody else really that provides the reports for ODC.
Thank you for the comprehensive update. I really appreciate it. One of the matters for escalation, of course, was in relation to the mental health electronic patient record. Yeah. I understand there might be an update on that.
Yeah, so shall I just give a brief update? So thank you, Chair. Thanks, Rachel. In terms of mental health, then about a couple of weeks ago now, we did have a positive correspondence through our colleagues in BCU. The Welsh Government had confirmed that they could finalise the procurement process. Running in parallel to that, though, I will just flag that there is a digital prioritising investment fund pro forma panel. How many words can I get in there? Yeah, exactly right. Which was held on Monday, which was reviewing all of the investment proposals. We're still awaiting the final outcome of that. So while we've had confirmation from Welsh Government to say we can complete the procurement process, we haven't had the confirmation on the funding yet. So, but you would hope, understandably, make an assumption that it should be okay. But yeah, we haven't had the final confirmation. So that,
moving in the right direction.
Yeah, moving in the right direction. Hopeful of getting a response now by the end of the month. That was what Welsh Government have now committed to following Monday's meet. So watch this space over the next few working days.
Can I just echo the thanks of our committee chair to you and the team for the enormity of the work. I mean, we have moved on significantly in the past few years in terms of that digital transformation space, and there's much more to do and get on with, but good grief, a lot has been delivered at quite significant pace as well.
Yeah, and thank you, Jay. And actually, it's not about me, but actually the team in Bridgend this week. So just for the board's awareness, we've now completed the site-wide rollout of EPMA Princess of Wales, and it's been a Herculean effort. We've had people working 24/7, obviously in staggered ways, since last Friday. I'm not completely driving them to but actually the adoption and the feedback is probably being in digital on, but it's probably the best I've had in terms of how the teams have operated. So credit to them, really. Not
well done.
Thank you.
It's the impact on patient safety as well.
It is,
for all of these systems that's the driver.
So we'll do the share on that in due course, but it's been really positive.
Kathy, thank you.
Yeah, just echo all of that. Really impressive work. But I think full credit to Stu and his team, but it's also a reflection on the organisation and their openness, their digital maturity to take this on, because I know I've done Stuart's job in a past life, and if your organisation isn't working with you, it doesn't work. So
and I think the EPMA is such a big opportunity, and having been talked to colleagues at PW and seeing you using it, positive. So often with these sorts of things, you go and meet people and it's like, oh, this is rubbish, that's slowed me down, that's terrible. But actually on this one, everybody's just universally positive about how well it was working and the ease at which they were able to use it. And I think it does reflect the fact that we've procured a solution that is also really user-friendly, very intuitive. It just hasn't needed loads of training for people on how to use it. It's a really self-explanatory tool. So
And I think that proactive support to teams, I know some people will have a view on the colour pink that was chosen, but actually some of the feedback has been, oh, I'm stuck, look around, there's someone in a pink t-shirt literally just yards away that can support straight away. And it's a different model to what we've done previously. So
we used to do regularly into this as well, the prescription error reports, which were ridiculously high. And already what I'm looking forward to doing is now comparing PAW with the rest of the organisation. There you go. And then as we go move through, I'm hoping all that will be shut down. So as Lana said, it's a quality and safety. Absolutely. So thank you. It's a huge effort. Thank you.
Thank you very much. Thank you, the update. We'll note the reports of the Operational Delivery Committee. Moving on to item 6, I'm just going to take the Chair's report and the Chief Exec's report before we take a break. So the report from me as Chair is just for noting, there's a point there just to ask you to endorse to ratify the affixing the common seal as captured in section 3.1 of the report. Just to say, of course, this board meeting takes place not long since the Senate elections took place on the 7th of May and the formation of a new government. A new cabinet minister for health and care has been appointed, and I had the pleasure of meeting Madon at Gwynfor this week, in fact, to discuss a number of issues, but not least the current challenges around the Health First Strike action. So that was very much on our agenda. We've also seen the appointment of 2 deputy ministers, the Deputy Minister for Prevention and Public Health, and also a Deputy Minister for Social Care and Women's Health. So a 3-strong health team in the Senate, all of whom, of course, will be important to us in terms of how we discharge our responsibilities as a board. And I'm looking forward to meeting them fairly shortly to hear about the Welsh Government's priorities, not just for the next 100 days, but certainly for the next 4 years. As part of those conversations, I will be reiterating to the new government that much of our work as a board is geared towards that transformation agenda. It is geared towards reimagining what we do and how we do it, ensuring that we are able to do more with and for the communities that we serve, so we can improve access, improve outcomes, respond to prevention, respond to challenges of the levels of ill health that we see in our communities, and making sure that we are able to support our workforce to be the best that they can in the way that we deliver the services that people rely on. So I think it's going to be very exciting, and a number of our Senate members have been, a small number, I have to say, of our Senate members from the previous term have been re-elected. So overwhelmingly, those who have been elected for communities that fall within Cwmtaf Morgannwg are brand new to parliamentary life. And I know that we will be setting out a programme of discussions to explain where we are as a board in terms of delivering our performance objectives, but also how we are going to reshape our healthcare services over the next few years. And we will do everything we can to engage with them in that really exciting agenda. So nothing else from me, except to ask you to ratify, if you can, the affixing of the common seal, as I said, for those matters captured under 3.1. Okay, sure. Thank you very much. I'll move on to the Chief Executive Report. Thank you.
Thanks, Chair. Just to update, as we always do in these meetings, that the escalation status of the organisation remains unchanged. We have the first, you'll remember there's a new accountability framework that's coming into being from the 1st of April this year, which sets out the process for oversight from Welsh Government and NHS P&I to all NHS organisations across Wales. And the level of intervention and regularity of meetings is aligned to the escalation status of the organisation. So as an organisation that is in TI for urgent care and enhanced monitoring for planned care, we have a schedule of meetings now for the next 12 months with Welsh Government and P&I, the first of which is on the 20th, so we've got P&I meeting on the 27th of May, and then our first escalation board meeting with Welsh Government is on the 28th of May. So that will be the first meeting under the new escalation framework, where we will obviously be sharing the performance improvement plans that we have for both urgent care and planned care. Also just wanted to update on the temporary service change in stroke services. You'll remember that previously we had made changes to the acute stroke services that were previously provided at Princess of Wales and Prince Charles Hospital, with a bringing together of that service in a single site at the Royal Glamorgan Hospital. That was down, you'll remember, to particularly at PCH, challenges around workforce stability and fragility, with a very limited workforce available to provide that service. That service change happened, and as we've had reports back at the board here, a whole programme of change and improvement has been underway within the stroke service since it was relocated to the Royal Glamorgan in 2025. In May 2025, we agreed that we would maintain those arrangements on a 12-month temporary basis, which would give us the opportunity to do the transformation change work, make sure that we've got the workforce model right, ensure that we had the support services around AHP services. There were big changes in the nursing workforce that were happening at the time, and that 12 months is coming up now. We haven't seen any negative impact on stroke service since the change, and there are starting to be now positive improvements in the way in which the stroke service is operating and the outcomes that we're seeing for stroke patients since the consolidation into the Royal Glamorgan. Those arrangements are obviously still in place, and we have a plan now, and Lauren has oversight of a plan that is looking to develop further the improvements that we've seen so far, and a willingness to, I think, a really positive impact that we've seen now with staff that are fully established, a consultant team that's much more robust and resilient, and I think a sense of positivity that's emerged in that team now since they've been in the one location. So we've been talking to Slice because we would like to extend that temporary change for a further 12 months. You'll remember back when we talked about the strategy for the next, as part of the work that Claire's leading on the clinical services plan, clarity about what we do with these services that are currently under temporary service change will be first part of what we want to address as part of that clinical service plan. So what we'd like to propose is we continue that temporary service change for a further 12 months, whilst we now work up the proposals around the longer term service model for stroke care across CTM. So I just wanted to, we had that conversation and agreed that at the EMB a few weeks ago, but the process of making sure the board are aware and cited on that, I just wanted to confirm with the board that that's something we want to progress. And Claire, did you want to add things?
Only to say that we took the impact paper, didn't we, through QSEC at the back end of last year. That the improvement metrics form part of the IPR each time. Yeah.
Thank you, Paul.
Oh, that's just strong.
Oh, so I apologise. Such a pause. I think perhaps apologies. There's more.
Arrangements next to the gas for change. I won't go through that. Also, just wanted, in terms of positive updates, pleased to say that we now have the work on the LHP site is progressing well. We have the contractors working away. The first phase of the groundworks has already been completed, which is a really positive development. And the contractor is beginning to build now the modular buildings that will be brought onto site in September to start the actual construction on the site with the buildings from September. So really positive developments there, and great to see that that project's coming to a fruition, and also that we've confirmed the independent sector provider as Alliance, who are going to be the people working with us to deliver the diagnostic services in the Community Diagnostic Hub when it opens. So really positive development there, and you'll see as you drive past lots of activity going on within the LHP site. So that's a really positive development. I also just wanted to touch also on the health visiting industrial action. We had notification on the 5th of May that Unite were planning to extend the strike action until the 17th of July. Clearly, we fully respect the fact that health visitors in Unite are wanting to extend the action, but it's obviously disappointing that we are going to see prolonged industrial action from that particular group of staff. And we are working with the service to ensure that the work that's gone on to date to maintain safe services in health visiting will continue. We had a helpful update to the executive team on Monday from Suzanne Harlandaker, the Director of Nursing and Midwifery, Children and Families, updating us on what's happening within the service to ensure that patients that need the services of health visiting are able to access it. We have had continuing dialogue with Unite, and those have included meetings with Unite and ACAS. We had 4 meetings, the last of which was on the 30th of April. Unite were clear at that meeting that they would not, that their only option on the table was to move all health visitors onto a band 7 job description. Clearly for us as an organisation, that's not a decision that we can make individually as a health board, because our health visitors are employed across Wales and indeed the UK, working to job descriptions that are nationally agreed. So the message we've been giving, obviously through both conversations with Unite, but also in our media conversations, is that the best way to try and resolve this is to participate in the national work that's underway, led by the Chief Nursing Officer in Welsh Government, to develop a suite of job descriptions for health visiting that recognises the massive contribution that they make to children and young families, but also recognise that these are national job descriptions that need to be agreed at a national level, so that there's a consistency of approach across the health boards in Wales. I did also just want to say, we have made representations to Unite also about the way in which some of the behaviours have been conducted in relation to the strike action. I just wanted to also highlight the particular challenge that Howell has had, and the personal attacks that Howell has been subject to, which I think we would all agree are unacceptable and not in the spirit of partnership working with the unions, and not behaviour that we would want to see. Howell's, when he's in negotiations with the union, is speaking on behalf of the organisation. It's not his personal view of things. So to target one person, I think is not appropriate and doesn't really reflect, I don't think, the style of interactions or negotiations that we would want to see with them. And similarly, apologies to colleagues, independent member colleagues, who are having other interests that they're involved in being disrupted by industrial action. We've made representations to Unite about that as well. Again, I don't think that is the sort of behaviour or way of working that we would want to see in terms of people being able to make their point effectively. Absolutely, everybody's got their right to make their point and to protest about the things that they feel strongly about, but it cannot be that we tolerate this sort of behaviour, whether it's to our own staff in our organisation or indeed to colleagues in independent members other interests. That really is disruptive and impacting on groups in our community. Just to also say that we are regularly now updating. You may well have seen that there's communications that we send out on a regular basis every week now, giving an update on what's going on within this in the dispute, because it's really important, not just for the health visitors who are involved, but there are lots of other staff in our organisation that need to be kept up to date. So we now have a weekly update that goes out in our all staff briefing to update colleagues across the organisation, because obviously people are well aware that this dispute is ongoing. That we are obviously present on around many of our sites on a regular basis. So I think it's really important. Colleagues across our organisation will also understand what we're trying to do to resolve this situation, and it's something we're in regular contact with government about. As John mentioned already, a conversation with the New Minister is already happening on that topic. Final point from me was just to also update on the proposed changes around shift patterns for nursing staff across CTM. This, you'll know, has been a process that's been underway for a while now. There's been an engagement process and consultation which was extended until the end of April this year, 24th of April. And there's been, this was a consultation on two options that were being put forward for discussion around a potential roster change for nursing staff across the organisation. We are obviously aware that this has a significant impact on a large number of staff across CTM, and that therefore we want to make sure that the process is handled in a really careful and structured way. So what we will be doing is that the feedback from the consultation process that finished at the end of April is being consolidated so that can be shared with trade union partners. We've also had, as you would expect, representation from trade unions about their views on the various options that are being considered. And what we will propose to do is probably a July meeting of this board, bring back the feedback report and a proposal of how we move forward on this, so that we can have that conversation with you. Timing is everything with this change, I think, because obviously this is potentially going to impact a large number of staff, into the thousands of staff, all of whom are going to need to have individual conversations and consultation about potential roster changes. So the implications of this change are going to be quite significant. So we've got to judge when we time this, so that actually we can do those consultation conversations at a time when there is proper time to do that. And clearly, with winter and things on the horizon, we don't want to get into doing that in the middle of winter. So we're aiming to bring that conversation to the board in July. I don't know, Hal, is there anything you need to add to that?
No, that's right. Just to say, since these papers were written, obviously we provided the consultation feedback to the unions. We're just in the middle of drafting, in consultation with trade union partners, the comms that will go out to staff, noting comments from colleagues just about keeping the momentum up in terms of conversations with our workforce. So we will do that.
Yeah. Thank you, Paul. Any questions or comments? Dennis, thank you.
In respect of the Unite dispute, I'm in full agreement with Paul that some of the actions they take in are very disappointing. It is an industrial action and an industrial dispute. But I'd also like to say that I'd like to record it that Howell has a full support of the board. He's acting on our behalf, and I'd like to record that Howell has a full support of the board.
Thank you, Dennis. I would echo that and say that not only does Howell have the 100% support of the board and the confidence of the board in the role that he discharges, but very robust support from the board to Howell. I do not tolerate poor behaviour. I accept that people have the right to take industrial action, and I accept that it is important that we are able to negotiate with our trade union colleagues in good faith. What I do not accept are individuals being singled out in the course of an industrial dispute for very personal attacks. It is unacceptable. I think that behaviour ought to be called out. It's not a standard of behaviour that I would expect to see from anyone. I'm equally sorry that organisations separate to our role as board members have been singled out by Unite for protest activities outside those organisations. Some of those organisations are small charities doing amazing work in our valleys communities, and to have the disruption and the intimidation of people shouting and blaring out music outside those office environments, I think is really quite poor. The dispute is with us as an organisation. It is not with any one individual, and it's certainly not with those organisations that we are also linked to in other areas of our lives. And I'm very disappointed that that activity has taken place. And I will continue to call that out as somebody with Paul as the chief exec, who is jointly responsible for the well-being of members sat around this table here. It's important that we engage, and I'm grateful to the efforts that Howell and the team have made to engage with Unite, but that does require good faith on both sides, and I think it's right that we place that on the record today. So thank you, Dennis. I very much appreciate that. Thank you. Patsy.
Yeah, two quick questions. How long can they continue to extend the strike, given there was one ballot at the beginning, and I don't know if that had a time frame attached? And to whom are Unite accountable? So where are our teeth? What can we do actually about this bad behaviour other than calling it out in a meeting held in public like this one?
Yeah, so just on the first point, so at the time the ballot took place, the law was that the ballot would last for a period of 6 months. So the 17th of July will be 5 months. They will have another approximately month to extend on that particular ballot. Subsequently, the Labour government has changed the law so that any future ballot will last for a year. So that's the and that doesn't mean the action necessarily lasts for a year.
The mandate.
It just means that the mandate does. On the second point, of course, there are various legal frameworks that govern the behaviour of employers, unions, all of that stuff. So ultimately, any actions are accountable in the law. Probably worth us having a conversation separately about some of those specific elements because they are complex. But as you'd expect, we are taking advice throughout to make sure that we are making our position clear on those elements of the law that we would expect any partner that we work with to comply with continually.
That's fine. Cass, okay.
Yeah, thank you. Same subject. I was just going to ask, I understand we need to follow due process around the job spec, and there's this expert partnership panel. Do we have any idea of timescales as to when they're going to produce the job spec?
So I think the job descriptions are in progress of being drafted at the moment, aren't they, Rich? Rich, they've been involved.
Yeah, they have. So they've been seen by our teams within the People Directorate, professionally with us in nursing, and we've sent final comments, as have other health boards then across Wales. So those will now be being considered. Can't necessarily give you specifics at the moment as to at what point and when those are transitioning to agreed templates.
They'll go into the evaluation then, won't they? Once the job description's agreed, then they'll be evaluated.
Yeah, so and absolutely important to say though that the normal process for that is that they're developed nationally in partnership. Yeah. They then become job descriptions that can be mandated. So the fact that Unite have chosen not to participate in that process, despite being asked to do so by the former cabinet secretary, they've decided not to. Other unions have supported that position. They are therefore not mandated job descriptions. So it doesn't, just to manage expectations, I guess, it doesn't neatly fix the dispute. It is helpful, but it doesn't necessarily resolve the dispute. And we will still need to work through the implications of those job descriptions with Unite and staff.
Okay. Any other questions to Paul on his report? Okay, not, we'll note the report. Thank you, Paul. We're now going to take a break until around 12:50. Thank you very much. Housemates. Ladies and gentlemen, welcome back. And if we can just move on to the next item on today's agenda, which is item 6.3, the NHS Wales Staff Survey 2025 CTM responses and priorities. I'm going to ask Howell to introduce the report, which is for noting. Thank you, Howell.
No worries. So, as Rachel mentioned earlier on, we had a good discussion about this at ODC, but I do still want to, if it's okay, just given the importance, go through it in a little bit of detail. Those of you not familiar, we run, and we're in our 4th year of running the NHS Wales Staff Survey, which serves as a point in time really reflection of the circumstances for our workforce and their feedback. There are some limitations with the survey, including participation itself. So notwithstanding the rate for CTM response rate has increased to 35.6 in 2025. I think that is lower than we would want it to be. Recency is also an issue. We ran this survey starting in October up until early December. We're still having some data coming through, trickling through from the survey now. So it doesn't give us a huge amount of time to do things on an annual cycle. So we've got to be quite clear about what the actions are that we take. The survey results will guide and continue to guide our people plan. So the initial people plan was developed on lists of specific people plan feedback, a look at some of our strategic priorities from a workforce perspective, and also staff survey feedback. We committed in that people plan to continue to listen to the feedback of our people when considering the actions that we need to take. As I mentioned, just shy of 9% increase response rate in 2025 compared to the previous year, which was 26%. The year before that, 18%. And the first year we did it, which was right in the middle of wave 2 of the pandemic, about a fortnight after Paul started, we had a 10% response rate. I think that was fairly predictable, actually, where we were at the time. But we are increasing fairly substantially year on year. When we ran our own survey at the beginning of 2019, we had a 40% response rate. So it does show we can do that when we want to. In terms of the substance then of the survey itself, we've seen a very marginal, arguably static in the engagement index score, which is around the 70.5% mark. Now, interestingly, the average score across NHS England, which measures it very slightly differently. It would have been great if we could have used the same survey, but the decision was taken not to, was actually they do it as a score out of 10, and their score out of 10 was 7.05, which is literally identical. So it's interesting. There are subtle differences in the measurement, but broadly speaking, if you look at international evidence, an engagement score of 70% is pretty good, actually. And we've seen one decrease at the opinion level that contribute towards that engagement index, which is Appendix 1 of the paper, which is around healthy working environment, which looks at things like burnout, health and safety culture, experiences at work, some of the stuff that we talked about around experiences of violence and aggression or aggressive behaviour, etc. Other than that, all of the indicators have increased. But again, worth noting that on some of them, we started from a lower baseline. On others, we started above is in Wales. So a bit of a nuanced picture. It's worth just having a look at that Appendix 1 when you've got time. And it also then identifies the sub-themes so you can kind of see where we're doing okay, where we're not. It can be a little bit confusing because some of them are negative scores, some of the positive scores. If you've got any questions about that, probably don't ask me, but I will find out how those are to be read properly. But generally speaking, fairly static on engagement index score, and probably at a time when we were expecting a bit of a reduction in that, given some of the things that might have been going on in the organisation at the time. So we've had some we've got the general roof, we've had some of the proposals around shift patterns, which Paul acknowledged earlier affects quite a chunk of our workforce. And also we've had lots of service changes, those types of things. And those issues do come up in some of the survey results. We've also had around 1,300 free text comments, which are, you've got a single box per member of staff, so they're 1,300 individual comments. We're just in the middle of working through as an exec team how we handle those comments and what we might do with those alongside the results that we've received in the main survey. We'll come back to you about that probably by ODC now, just to talk about that some more. Just in terms of that sort of accountability and priorities, over the last couple of years, we've changed the way we do the survey because we've had more granular data. So the higher your response rate, the better the data you get. Simple as that. And because we've increased our response rate, we've been able to move away from what had previously been a largely sort of corporate response to the survey, which we still need to do. There are organisational themes, to working at a granular level with care groups and directorates to take action locally to improve the working conditions for their teams. So we continue to do that, and I think that continues to mature. Probably last year was the first year that we were able to do that. This year, again, we've seen really positive engagement from care groups at different levels of maturity. So we've got some that have really grabbed hold of it, made some changes locally and seen some real engagement on the back of that. Others are more at the beginning of that approach, but hopefully this year we'll be able to take some action that demonstrates we're listening. And the feedback we've had directly from staff is that the more they say us do something with the results of the survey, the more likely they are to complete it. And certainly anecdotally, when I was sort of out there, I did quite a few of the sort of start survey roadshow sessions, and that was certainly the feedback from a lot of people. Where we do need to get to, though, is that it's owned at all levels. So I had a couple of managers say to me, well, what are you going to do with my staff survey results? Well, okay, yes, we do need to respond to them organisationally, but it's more about what are we going to do, what can be done locally. Some of these are done local, some of them really are organisational, and we need to think about them in that way. So having gone through all of the data, a couple of weeks back now, the data was presented to execs, and a couple of areas have been identified for focus. This year, I should just say, though, before I go on to those, where we've identified specific areas of focus in previous years, we have seen tangible differences. So the first year, we did a huge amount of work corporately on flexible working. We've seen a marked increase in our flexible working scores. Last year, we did some work around speaking up safely, and we have seen a significant improvement in our raising concerns score, which is really positive, and it benchmarks above peers across Wales, which is excellent. Alongside that, we've also seen an increase in our patient safety metrics in the staff survey, and indeed those also track higher than our peers across Wales. So that's good. However, we also need to be realistic that picking new topics every year and giving ourselves a couple of months to do something is quite tricky, actually. So we do need to be quite fleet of foot and possibly just comfortable with the fact that we won't always necessarily be able to change something we've identified in April for a survey that's done in October the same year. So we can kind of give ourselves a break, I guess, on some of the things that may be longer term. So the main areas that have been identified are around mistreatment of our people by patients in the public, which unfortunately has been on the rise in recent years. So I think Rich, has very kindly agreed to take that on in terms of leading a piece of work to examine what more we can do there to support our people, but also be really clear with our population as well, and indeed improve our training compliance in violence and aggression training, etc. Secondly, then people's involvement and experience of decisions and change. Perhaps unsurprising, given some of the things that we've needed to do at a bit of pace over the last couple of years. People have felt that we've made decisions and haven't necessarily been able to take them along with us and give them time to I think that's fair. So, needing to be reflected, haven't we, for example, on the work that's been done in palliative care today, and indeed other areas, the best change happens where we're able to do that work with staff and to co-produce, for want of a better phrase, some of that work with our people. So that's, again, another area of focus for us. And then the last element was a theme around well-being generally, and the need for us to have better quality conversations with people about how they're doing and how they're feeling, linked to burnout and other things. And then perhaps unsurprisingly, we've got sickness rates that are quite elevated. So all of these things link together. So quite a bit in there. I've also been having some conversations with my team more recently as well about how do we track these things in a more live way. So, it's not a great message, is it, that we care about you and what your feedback is, the extent to which we ask you once a year what you think. So we do, I think, need to get into the habit of more regularized pulse checks. However, we need to make that proportionate, useful, and also linked to our priorities. So I'm not proposing to rerun the survey every month. It's a 100+ question survey. It looks at the need for other regions. But we might, for example, if we're looking at a particular priority in a particular year, we might just say how we do it on it, for example. So we are designing that at the moment. The real benefit as well in that is it enables us to have a better conversation with line managers about owning some of the results, because we will be able to pull that down to a lower level than the national staff surveys might be able to report to. So there's some real benefit in that, we think, for us. So very generally, I think we're making progress on both participation and indeed some previous areas of focus that I mentioned. Our target for next year, I think, is 50%. Average across NHS England is 49%. Highest in NHS England, 66%. 50% is doable. We should be shooting for that. I think we do need to change our approach. Can't be, my team go around and harassing 14,000 people with a clipboard. That's not a sustainable approach to this. It's got to be an owned metric for us. There are some clear areas of trending decline, which I mentioned are some of our priorities that we're going to focus on. And obviously, we need to make sure that we're communicating effectively what we're doing out to our staff, letting them know that we're acting on the feedback that they've given us. We also need to reflect on kind of how we increase the rate for next year to 50% of membership. So that's probably all I wanted to say, very high level, but welcome any thoughts, and we've had a good discussion about it with BBC as well. Thank you.
Thanks, much appreciated. Dilys and then Hayley. Thank you.
First of all, I'd like to congratulate you on the increase. I mean, we've more than doubled the response in 2 years. So, sometimes we can be a bit negative, but we've only got 30% and we wanted 40, and actually we've more than doubled in 2 years. So I think you need to look at it that way. It was really pleasing for me to see the results I was speaking at and raising concerns, because I know there's been a lot of work done in respect to that over the past couple of years. So it's really pleasing to see that is working. I also took part in the road shows and had varying degrees of reactions, shall we say, from, oh, that's rubbish, to we're all doing that, and I think it was, especially Cumberland, the staff were really keen to do it, because I think they almost had a competition about which department or which section of the hospital with so perhaps we need to tap into those areas to encourage other areas to have the same response. But yeah, well done to everybody concerned, and I did really enjoy the road shows, even the ones where people told me I was asking them to fill in rubbish. But it was really good to see the varying reactions from the staff. Yeah.
Thank you, Dilys. Hayley, thank you.
Thank you. Yeah, the staff survey and the people plan, I'm really advocate for this. I find that some stuff that it's quite easy to collect data on, but actually when we want to be improving people's well-being, then this is really helpful and tool that is going to help us do that. I guess, and work that we've done before, which has been brilliant and obviously is spurring these changes, are things I think are quite sort of solid. Yeah. It's against policy or it's against this or that, which is really easy, isn't it? And this other stuff that we're doing is sort of in that kind of grey area where we're really not quite sure. And I suppose what I'm really keen for, and Gethin brought this up when we did I joined the what's it last week, is yes, we want managers and it's to be taken account locally, but really emphasising that it's not for managers to do, it's for managers to engage with their staff and say, right, we're looking at this theme, how are we going to make this better as a collective, you know, whereas I think a lot, like last year, it did seem very much like this is an extra thing our managers have to do for us, and that sort of engagement with the staff was lacking a little bit. So I think let's really strengthen that this year, and I think, you know, hopefully we'll be able to get a little bit more of a hold on this sort of like nebulous stuff that's hard to because of a policy.
Dom and then second Dom.
Yeah, thanks. I was not at ODC, so I had to go to another meeting, so I'll raise the points I was going to raise then. The session I did last week fed into my pre-existing concerns, which is about violence to staff. Yeah, it's very horrifying, isn't it, looking at these numbers here. I think let's not go into that in detail because I know Richard leading on a piece of that, but I suppose the other element to that we also need to work on is within our teams. It's, you know, between teams, between, you know, specialties, you know, it's that into bullying culture as well, undermining, putting people down, abuse from that direction as well. So it's not all from the public on one staff, we're doing it to ourselves as well. And it's to reinforcing our values and behaviours, isn't it? But it's they're intertwined, I think.
Cass and then Paul.
Yeah, thank you, Hal, for that really comprehensive paper. I was really pleased to see in Appendix 2, the first one about involving staff in change, because when I go out and visit and hear from staff, they sometimes feel they're not involved enough in change. And as we transform as a health board, it's going to become more and more essential, isn't it, that we are hearing their voice and they're involved and they're owning it. So I just wanted to say it's great to see that on the top of that list. Thank you.
So Paul and then
yeah, so I mean, agree with everything that's been said. I mean, this is a big opportunity, isn't it, to get a sense check of how it feels. And the more we get an uptake in response, the more representative it becomes, because there is always a danger of these things where people are generally okay and feeling they've got nothing to complain about, don't fill in the survey, and the people who aren't, they do fill in the survey. But, you know, as we start to edge up the response, that starts to become diluted a bit. We get a more representative piece. I think all of this, a lot of this does come down to the organisation, but the start reality, and we've had this conversation, Hal's mentioned it already, is a lot of it is people's experience of where they work in their team, in their ward, in their service area. That is largely what drives people's experience at work. It's not whether I say we've got compassionate culture in this organisation. Do they feel that in their team, in their, you know, when they put in a request for flexibility around their roster, is it welcomed or supported, or is it no, it's a stupid con of that? You know, because and that is, and we know we've got variability, and I know I bang on about this all the time, but the fundamental group we've got to really work on with this is our line managers. As line managers have probably the most difficult job, because we're pushing down the stuff to them to say we need you to do all of this, and then they've also got all their staff and their team saying we want to do this, or I need that. So I think there's something in this about how we really support, and I know how we're doing a lot of work, aren't we, with that group of people in terms of putting in training around the sort of how do you have difficult conversations with people, how do we induct people into management jobs, because quite honestly we often find people are really good, they're a band 6, I don't know, deputy ward manager, and we say, oh, you're really good as a band 6 deputy ward, here you are, now become a ward manager, off you go. And then we're wondering, oh well, why are they not, you know, so there's something for me in all of this is how do we support managers and leaders in the organisation at every level to be creating those cultures in individual organisations, in individual teams, sorry, as well as all the things that Hal's rightly described that we've done corporately in terms of the policies and things, you know, things that are a bit frustrating, aren't they? So you look at the stats around things like flexible working. Well, actually, we've got really flexible, we've got really good policies around flexible working. So somewhere along the line, if people are saying they're not giving opportunities for flexible working, then somewhere along the line, it's not the fact we haven't got a policy, it's the fact that somebody's not reflecting the policy into their team or supporting that policy in the team. So this is the balance we've always got in this sort of stuff, is in an organisation of our size and scale, is there's so much we can do at a sort of corporate level, but the reality is a lot of people's experience is driven by how, so when they talk about not involved in change, candidly, that's not necessarily about whether they're involved in a change in the clinical services plan for the next 15 years. you know, what does the roster mean for our team, or why have we decided to move that, I don't know, examination couch from that room to that room? No one told me. You know, it could be as basic as that. It isn't all about being involved in, let's not be into the, you know, everybody in this organisation wants to be involved in the big strategic change of the organisation. They want to be involved in the change that directly impact their work. And I think particularly, Howard, as you highlighted, things like rates about the rosters, that's a real concrete thing. Now, I would hope that people would feel, whilst they might not like the answer necessarily that comes out of it, but at least making sure that the process is as inclusive as possible. And we've worked with the unions and others on that to ensure that as many people can have their voice. Really important. My final point is, I think the unions also have a really important, like, hey, your point about this being a really important thing for us. The more we can present this, not just as a corporate priority, but that getting our trade union partners on board, highlighting staff through their membership, saying it's really important you fill this in, because actually this is listened to by the organisation. It is a really important way you can hear it, because there is sometimes an inbuilt cynicism about, you know, oh, it's an organisational thing. And, you know, we have to deal with this whole issue, don't we, about everyone thinks, despite it being anonymous, there is still a perception that we can track back everybody's response to find out that it was, you know, it was you that said that about this. So the more we can, I think, in the next iteration of the comms around the survey, get that being jointly led, which I know the unions have been heavily involved.
Yeah, absolutely. Well, we a lot of us have been joining the roadshow as well. Put it our way.
Rachel, and then Lauren. I'll come back to Howard for some final reflections. Thanks, Rachel.
Thank you. Well, I would be interested to know the English organisation that has achieved 66%. How have they managed to do that? I would be really interested to know, are we learning what they are doing to achieve that? But also, I'd be interested to know the scores within that score. Sure. So, you know, 66% response rate is just one percentage, but in that, what are the other scores around, you know, the engagement, involvement, etc. But I think if they cracked it and they clearly seem to have, then
So we are. I mean, an interesting then has been at this for 23 years. Yes. So the survey in England started in 2003. I was started in 3 or 4 years ago. So bit of work to do. But yeah, absolutely, there are well-known evidence-based things that we can do to increase the response rate. Yes. But yeah, and in terms of I haven't examined their results, but we can have a look at that. Of course, we can. We benchmarked ourselves against NHS England as a whole and NHS Wales. We're broadly around about the average. But in some areas, we benchmark higher and lower, as always with those things. Broadly, that's where we're at.
I think just on having worked in an English trust, Simon, I can't remember, what did we get up to?
I'm just looking back.
We were up in the 60s, I think, weren't we? 60 or 70 or 70.
70, I think 71.9.
71.9.
Because the numbers are going to say.
But as Hal said, it becomes ingrained in the way you do things. I don't know, and Claire's had experience doing
this. And it is also easier because you're not such a diffuse range. So you've got small, but arguably.
You can go and eyeball people pretty much in every part of your
So it was easy to chief exec in his previous gig, is that what we're saying?
Yeah. Why don't you listen? I'm just highlighting since I've arrived.
Hang on, right. Lauren, next.
Thank you. Just a very brief comment. I think these priorities are going to land really well with our teams, aren't they? They're the conversations that we're having when we're out and about. And I think there's a benefit in making the really explicit connection between positive, healthy relationships between us and between us and our patients and patient safety. So there's a really strong evidence base in there in terms of stability saves lives. So whether that's something that's in terms of motivating teams to engage at a local level, that direct correlation back to patient safety, I think it's a really strong message.
And I just quickly, because I do think one of the challenges we've got, and we've talked today about 2 very difficult changes that we're making. And we know for some of those staff, they won't feel, A, that they've been involved, B, they might not like the outcome. So I think there is something for us about, as we look to the future around our clinical services plan and similar things, there's a really important question about how do we present things to staff? Because engaging with staff doesn't mean we can always do everything that people want. And sometimes there's a sense of disappointment where people feel they've engaged, given their views, but their perception is, well, you've not listened to my views because you didn't agree with what I said. And I think that's a really tricky thing to handle, because you can almost, by going out and engaging everybody, it raises an expectation that, well, you've listened to me, but you didn't act on what you heard. So where we're not responding in the way that they would have liked, we need to think carefully, I think, about how we describe why we arrived at that decision, because sometimes that's the challenge of these sorts of jobs, is we're having to make decisions in a much broader context than often people appreciate in their own service or own team. And I think maybe there's some learning for us about how we do that going forward. And, you know, the YCC example is very rapid.
Yeah, I agree. I think some work around, and we've had some conversations about it previously, but just about how we do change, even the language we use.
Yeah.
So we call it an OCP.
Yeah.
We take a psychologist from my team, which says we're doing something terrible to you. Here's a person to fix you. Well, it's not surprising that people have got antibodies. So there is something, I think, about how we frame change in a much more positive way. But also when we've just got to do things for a particular reason, we're really honest about that. We don't pretend otherwise. So learning there for us, I think.
I think sort of with that sort of element, we're maybe not particularly as strong as maybe the feedback. So the explaining, like, we've done this and therefore it means that. So when we started in the care group levels of, you know, you said together that had a really positive impact on staff. So anything that we do, I think that level of feedback after the engagement is super important, and that's a really nice, good way of doing it.
And do we have the dates for the next October?
Before we know it.
If I'm being clear, actually, I appreciate how resource intensive it is. I'm really grateful that board members engaged in that. And from my experience over the Royal Glam, we urged you to have a stall and a cafe, but we double booked with somebody else. So we ended up walking around all the wards talking to staff, which quite frankly was a far better way of doing it. And like I say, that helped to boost the numbers. But at least it did allow a conversation with people. Although in a busy environment, it was still quite nice to see them on the wards. But you can't do all of that everywhere. So it is quite a challenge to resources, isn't it? But if we need to be mobilised again, Howell, I'm sure board members would support the next rollout of this. Sorry.
No, it's just about the pulse survey and when that will.
We're just working it out now, to be honest. We're just trying to find a mechanism to do it, but hopefully quite soon.
Yeah.
So we want
to get two in before.
Yeah. So we're going to very quickly trial it. It's not like a big huge pilot thing, just to see if it works, and then get on with it and then start doing that.
It's also a really good way of doing it. You said we did, like we are doing these things, and look at the changes we've made,
and they make a difference.
Okay. Thank you all very much. We'll note the. Oh, sorry, Helen. Apologies.
Sorry. I just agree with what Paul said. Really. I think it's for managers to own this, but it's clear from the discussion there's not just one solution to increasing the engagement. Clearly, there's been good progress. I think that should be considerably more progress, if I'm honest. But I do think that it's for managers to be engaged. But I also think there's something about the visibility of the exec team and the board as well. So I agree completely, Paul. People are affected by what hits them on a day-to-day basis. That's what's important, isn't it? But if they know that they can come and knock your door or speak to Gethin or Howell, if they've got an issue that is that kind of organisation, I think that makes a difference to whether people will engage or not. But there isn't just one solution to this, I don't think. I do think we need to be careful there's not overkill, because my experience from the civil service is that it comes around and people go, oh, we've only just done one and now we're doing another one. And there really is something about how you communicate the outcomes quickly to say we did listen and we did do this. And that the trouble is here, you might be doing something for someone over here in group A, but you're not doing anything for groups B to F. And that's the problem with it, isn't it? It's not, there's no easy answer to this, but it's good progress.
Okay, thank you. Sorry, I missed you. Apologies, Helen, for missing you earlier.
So I was waving to you seven.
Sorry, fine. My
hand up next. I would think anyone just.
Thank you very much. Thank you, Hal. We'll note the reports. Much appreciated. We'll move on to item 7 on the agenda, which is sustaining our future. And 7.1 is the month 12 finance update from the previous financial year. Thank you, Sally.
Thank you. I'll do month 12 and then a verbal update on month
Super.
1 at the same time, if you don't
Yeah,
mind.
that's fine.
So, obviously, at this stage, it's the funny part of the year for us. Funny. Is it amusing? Strange. So we've obviously submitted our accounts in line with the timeline. So any of the results reported here are subject to audit, and we have to keep saying that over and over again. I think I've said it many times at audit committee earlier in the week. So it is draft accounts position. So, and will remain draft until they've completed their review, which will be in June. So what we're reporting in terms of the draft accounts is a 50k surplus for revenue against a revenue resource limit of 1.617 billion, which is a 0.003% underspent. In terms of capital, 79k.
You said again, we slightly underspent.
Slightly underspent, 50k surplus, safer side of this, against 1.617 billion. 79k, that's also just audit.
Quite a few more pencils, and that would have been square on zero then.
No, you never end up exactly on zero. So 79k surplus for capital against a final capital resource limit of 105.1 million. And there was as you know, a huge amount of expenditure towards the latter part of the year. So that's a real positive investment. It's our largest ever capital programme in estate, in infrastructure and equipment, and in digital infrastructure as well. So hugely beneficial to have achieved that level of spend. 4.9 million cash balance as at the end of the year, 95.6 of non-NHS invoices paid within 30 days, which is our target. 74.3% of non-NHS invoices, and Welsh Government colleagues have pointed that they would like that to improve. So we will focus around that. So with an approved IMTP in place and this draft position, we will have achieved our statutory duties for revenue and capital, which is helpful. But again, all subject to audit. So I just want to acknowledge that in arriving at these positions, this is a huge collaborative effort across all our services, our directorates, our care groups, and the finance teams and business partners working alongside them. What we've seen is better forecasting as we've gone through the year, which allows us to take corrective action to move and to land up on the position we need to. So it has been a huge effort across the board. We do, of course, now move into another year, which presents a whole set of challenges. Just to reflect, thinking about some of the conversation we've had at audit committee earlier this week, where did we end up on savings at the end of the year? So we reported 25.7 million achievement against the 31.3 million target, which is a 5.6 million under delivery savings. How that was made up was in terms of the delegated target, i.e. care groups and facilities, there was an undershoot of 5.5 million. Our CTM savings, which is the primary care prescribing, it's reimbursement prices, and it's a mechanism that releases cost as we go through. 5.1 overachievement. Energy savings for shared services, the new contracting mechanism gave us a 0.7 benefit, and the variance on the centrally led exec programmes was an adverse of 5.9. Together, 5.6 off. We've had to absorb in the year some significant pressures, particularly in terms of some financial allocation shortfalls from Welsh Government. In terms of national insurance and pay awards was 3.8 in total that we absorbed. And it's worth just flagging that despite over recent years, and we've come to this in terms of the budget paper, we have basically supported the deficit position of our care groups each year and increased their budgets, and 78 million has gone into frontline services over the last 2 years. However, it's continued to deteriorate with an overspend against budget of 15.2. That's why we're adopting a different approach for budget setting for this year as we go into 26-27. So we do need to address that. We can't continue to see that overspend increasing. So saying that, we'll come to month one. So month one, we've reported to Welsh Government earlier in the week, and our month one position is a 1.4 million deficit. Saying that, the major issue within that position is savings delivery, and we do flatline our savings planning. So we would expect it to improve later in the year, but significantly more work is required to improve our plans, because we've still got gaps around where we are in terms of savings identification. So a lot more to do in that position, so we will need to keep a very careful eye on that. We have identified a significant level of risk. You know, each year we're required to identify that, and at month one it's 50.7 of risks. The most significant being Welsh Risk Pool, which you'll recall from our IMTP, we submitted an Exec 4 plan, and the 18.4 million planned plan growth will be funded by Welsh Government if we deliver the plan. But clearly we have to identify the risk that we won't deliver the plan and therefore won't receive that funding, or won't have that benefit provided to us. Mitigating actions still to be achieved of 16.7 million. Risk assessment of unfunded cost pressures, which sits at 11.2. JCC performance risk of around 2 million, and not delivering forecast savings at 1.6. So across the year, we will now try to reduce those risks as far as possible. But that 18.41 will remain a risk, I would suggest, until we get to the year end and we know whether we've delivered the position. So I just want people to sort of see that context. So happy to take any questions, but that sort of summarises where we are for both year end and month one.
Questions to Sally on the month 12 position and also on the verbal update on month.
Well, I'm not a question, just to say well done. I just echo what you said, Sally, in terms of fantastic. I mean, absolutely amazing to have a 50k surplus on a £1.7 million budget.
Yeah.
And it's just makes you speechless, really, in terms of the ability of the organisation to have done that.
It's getting hotter and hotter.
Sally, one of the things we've discussed in previous meetings, board development sessions and meetings here, is that all too often some people outside of this environment think that with an attempt to deliver a break-even position, that somehow we are then deliberately not investing in supporting the delivery of our services which our communities need. Now, I know that is not the case. Would it be possible to outline to the board, if you look at the past, say, 3 years, where we know through the allocation to care groups, for example, we know that one of the challenges has been that our care groups have invariably gone beyond their allocation, so they have spent more than was originally allocated to them. And we've had, obviously, we've supported that expenditure by making decisions elsewhere. I think it's really important for us to get our the messaging. I think, Simon, particularly when we start to talk to new Senedd members about how we are able to manage our resources in a way that allows us to support, our care groups to deliver the services that we need to deliver for our communities. Because sometimes people think that if you're attempting to balance your budget, that we're somehow not spending money the way that we should be, but we clearly are.
Yeah, our expenditure has continued to rise across all of our headings each and every year. There was a moment when I looked at the accounts and it said we were spending 3.4% less on hospital and community services, and it's like, why? And then you go, you net out impairments, which is where we write down fixed assets, and actually we've spent 7.2% more. So you can see those percentages and how things are moving. I think for the next strategic delivery committee, we will bring some analysis that tries to break that down and use some of the different sources to show how we are moving our spend, how we're improving services, and how we've put significantly more in. We have more staff now than we have ever had before, and we have more investment into this community than ever before. But we are the only health board in Wales that has delivered break-even for the last 3 years, and that's statutory duty. And I know that then brings the pressure around are we doing the right thing? But spending our money wisely
Is doing the right thing.
is doing the right thing, because it's a statutory duty, not a sort of, yeah.
Plus, as Paul said before, it allows us then to also focus our minds and our attention on other things that need to be addressed. And I'll bring Geth in. Geth?
Yeah, absolutely. And I think, we have put in more and more resource into the care groups in order to deliver the clinical services we want. And if I link back to the conversation we had at the beginning of the day and the work that Claire's leading around the clinical strategy, we have a number of clinical services that are really fragile and within the health board that we are propping up with really, really expensive service models. And there comes a choice, a point where we're going to have to make a choice about spending our money as best we can for the outcome of our population. And some of that's going to require us to deliver our services in a different way. And it is really important where we've made those investments that we really do focus on spending the CTM pound as wisely as we can for the best outcome for the CTM population. And that will require, no doubt, some more difficult decisions around some of our service portfolio and how it's distributed, but those are really important conversations we need to get into so we can invest in more services and the right services for our population.
Yeah, so I mean, I absolutely agree with what Catherine just said, and I suppose, as Sally's rightly highlighted, we shouldn't. It's really important that everyone understands we have, I can't remember what the absolute number is now, but we have X number more people employed now in our organisation than we did a few years ago. Now, nationally, that is a pattern that's repeated in every health board across Wales. But there is understandably the question that comes with that, which says, so we've got more people, why aren't we seeing quicker improvement in performance? So, you can expect, or we can expect, there will be a greater degree of scrutiny on productivity, efficiency, saying, well, hang on, we've got all these extra people. We shouldn't be therefore struggling to see people more quickly. So there's a lot of work that we're doing internally within our own organisation, looking at where's our headcount growth been, how are we ensuring that we're getting better activity and productivity from the workforce we've got. I would draw you back to the health sickness absence report. When you've got 8%, 9% sickness, as Howard says, on any day that's 800 people in our organisation that aren't in work. Well, that's not particularly productive use of our workforce, is it? So all these things do all interlink because they've all got a benefit. Because when if we've got people off sick, we have to bring in staff to cover them, and that's costing us more money. So all of the steps we're taking around productivity, managing sickness, increasing staff engagement, all of these things are contributing as much as budget management. They're also things that influence how our financial performance gets delivered. And candidly, as John said, I always say this, don't I? But it means that we have the headspace to get on and do the interesting stuff. It's no coincidence that we had the biggest capital programme last year in Wales. Part of that is because Welsh Government gave us more capital money because they could see we were delivering on our financial performance. So so we need to be able to explain to our colleagues that by delivering our financial obligations, which is, as Sally rightly highlighted, a statutory obligation. Absolutely. If you're sat in a local authority, you have no option. You have to balance your budget every year. There is no choice. And so I think we need to be able to show to our staff that actually by delivering our financial performance, A, we've been able to invest in lots of things we want to invest in, and B, we've been able to put money into things like capital projects and equipment and improving the environment in which they're working to a greater degree than maybe other organisations have been able to do in the past. So I think it's a really positive achievement. And I think, the challenge now is, right, deep breath, got to do it all again this year. So I think, it's a challenge. But
before I bring Dom in terms of doing it all again this year, I think what might be quite helpful is perhaps for the July meeting, if we could get more of an update around the efficiency savings plan. Because we know that we've had to say it again this year. We'll increase the ambition in terms of the savings plan. Obviously, that takes a colossal amount of effort. I'm really conscious of the effort that everyone's put into delivering as much of that as possible last year. But I think it'd be good for us to we could do that just to do that for the high level overview. Yeah. Cool. Sorry, Rachel, you want to come in? No. Dom.
Yeah, it was just a quick point, really, just caring about the headcount sort of thing. But yes, we have increased our headcount across it, but actually CTMs have the lowest whole time equivalent increase since 2019, 2020 from all the health boards. So yes, overall our numbers might increase, but we are getting more or less than full time people in. We're now converting far more temporary into substantive, so that's going to increase it, hopefully reducing the costs as we go through, but it will put the core costs up. And we've been safely investing. So just as Gethin was saying, in our ED departments, in some of those fragile areas, we've been trying to sort of recruit into, but some areas we've had to overexpand. So there's a lot to it, and I had a whole load of data sitting here right first thing, like just pressing the delete button on it when I started.
I think
So it's an
Howard
outline.
has got the number of our headcount growth.
Yes.
Well, hold on.
13,400 to 13,800, I think it was, from memory, from 2 minutes ago.
So in terms of full-time equivalent on the payrolls, obviously, doctors who are employed by the SLE model are not included, but we had 10,200 full-time equivalents in 2019. We've now got 11,800, so we've grown by 1,600, around about 15% growth. And some of that, I would argue is positive. Yeah. So you remember some of the conversations we were having about nursing vacancies a couple of years ago. We've got 630 more nurses as a health board than we had 7 years ago. That's a positive story. However, there are other areas where we need to be more efficient and consider alternative models of doing things as well. And also the stuff around sickness, how we use how we deploy our workforce, rostering, all of that stuff needs to form part of that work that we're doing.
Yeah, I'm just building on that. I think understanding that the growth in the headcount, the story behind it, we also need to unpick, the health of our population hasn't stood still either. So it's about understanding the complexity and demand, whether that tallies.
Yeah, thank you.
Okay, so we'll just note the update and the month one will update. Thank you. And we've got the financial accountability and budget framework.
Yeah. You'll be relieved to hear I won't go through this in exhaustive detail. I'm just going to draw out a couple of things. So this largely reflects what we've already approved, or entirely reflects what we've approved as part of our AMTP in terms of what's here in terms of the details. So I won't walk us through, otherwise we might be here until tomorrow. I think just to go back on that point, it does make the point that over the last 2 financial years, the delegated baseline budgets were increased by 44.2 million in 24-25 and another 33.8 for 25-26. So significant increases. And what we're going to do for this year is not to increase the budgets to reflect their over-expenditure of further 15.2. But Gethin and I have had this discussion. This paper has been to EMB for agreement that we start to challenge people to bring their budgets back into line. So then we can start to think about the things that we all want to do about investing in other areas rather than simply moving more resources to expense. But it is a process of ongoing dialogue throughout the year. So the inflationary pressures are covered off and how they're treated within this. And there are some very specific ones. The recurrent cost pressures as well are detailed out here. Again, these match what we discussed and approved as part of our IMTP. And then we have sort of set that out in detail for how that then flows through into individual budgets and where we're holding some central reserves. So in overall terms, I'm recommending this to the board for approval. Under our standing orders, it requires board approval, but it's had discussion and endorsement from execs.
Thank you very much.
Yeah, I had a question on point 2.2. I just didn't quite understand the 2 tables around the recurrent deficits. The 9.2 million compared to, I think it what's supposed to be 18.88 million.
Yeah, those are the recognised deficits in the care groups and other elements. So it's not the organisational one, it's the individual budget summary there. So that was what we were recognising at month 9 and then how it changed over time. So we can see that planned care, for example, by the year end deficit we were recognising there was 7.2 million, 7.251.
Does that mean that 18.8 is our underlying deficit then?
No, our underlying deficit across the piece is 9.2. We were supposed to come into the year with a positive of 1.7, but it's a 9.2 deficit overall. So it's what's in delegated and what's in non-delegated. Happy to go through the detail outside if you like.
Yeah, so I don't quite understand the 18.9
Yeah.
in terms of how that relates to the 9.2.
This is the care group or director of current assessments. But there's also a piece where we ask everybody to say what they think their underlying position is.
Okay.
And sometimes that is quite negative in terms of its position, but it's worth you understanding these are the risks that they're reflecting. So when we talk about in our risk assessment that I just described for month 1 of unmitigated cost pressures, some of these things will feed into that.
Oh, I see. Okay.
Yeah.
Thank you.
Any other questions on this item?
Just sorry. So, once we review this, and we'll then send out delegation letters to all of them.
Yeah, the budget delegation letters will go out, and Paul's aware that this is a focus for Welsh Government colleagues around the leadership board about has this been through boards and have we got all the accountability letters out to people. So we will move quite quickly to do that.
So Sally, just to confirm, this is for approval?
This is for approval, please.
Fine. Okay, thank you very much. Unless any other questions, colleagues happy to approve? Yes, thank you very much. Okay. Just move on to item 7.4, which is the capital programme update 2025-26 and 26-27. It is for noting, but there's one item in here in relation to the disposal of the Pontypridd Cottage Hospital, which is for approval. I'm sorry.
Yes, so this takes you through in quite a lot of detail all the various capital funding elements that have been in the programme for this year. As you can see, 105 million, as I talked about earlier. It is the largest programme that we've had until we come into this financial year when we're going to be at 140 million. So again, another significant step up reflecting the LHP developments and phase 2 and phase 3 of PCH, ground and first floor improvements. So there's been significant work throughout the year to arrive at the position that we did was a testament to the work of the teams, to Stu's team in digital who had to acquire a lot of things in the last part of the year, and also to our procurement team who work with us from shared services and have had to respond to significant additional capital becoming available and have worked with us to achieve that. So it is a significant programme. The discretionary programme for next year, as you go, or this year, which year am I in? It shows here in the table how our discretionary allocation has moved over recent years. It is still a remarkably small allocation given the extent of our responsibilities, 3 DGHs and everything we have to do. So obviously all the top up to 140 is just through various other programme or Wales programmes. But that is what we've got for what I call our keeping our lights on capital. So for this financial year, it ends up with 10.8. We overcommit. So why do we overcommit? Because schemes don't always deliver on time. Things take more time. Some things pop up that you're not expecting. So we overcommit and then try to manage that down as we go through the year. It seems a bit odd to sit here and say we're overcommitting by 25%. But given the range and complexity of schemes, just trying to get into clinical areas to fix some things is important that we do, but it means it has to be very carefully managed towards the year end. We've got a lot of work which will go on in terms of targeted estates funding, which going forward, and you'll remember the refit programme that we've approved as well during the year. So in terms of our discretionary allocation, we've got an approved distribution that we've used traditionally, which forms part of our IMTP. So for those of you who will notice, ICT gets a sort of 19% share of the pot at the start of the year, but by the end of the year they have usually increased substantially as they're better able to deploy spend later in the year. And that's fair to say, isn't it, Stu?
Yeah.
Yes. And we try to make sure that we've got available schemes that we can bid for or put in place should additional capital become available. And that's very important in being able to secure those funds as we go through the year. So in terms of our IMTP for this year, the major projects are, as we said before, Lanchester Health Park, and then the final phase of Prince Charles Hospital ground and first floor scheme. So the phase 2 scheme will just be concluding during the year, and then phase 3 is already started. And then we should finally lift the fire enforcement notice that has been in place since about 2011. Longest ever. And significant improvements across the site. I think you can agree where you can look at it. So there's a lot of work within here. I'm quite happy to take any questions, but it sets out that. And as we just said, in terms of disposals, we did sell Pontypridd Health Centre last financial year. That completed finally in February 26th. It was quite a painful process. We transferred Bryn Cefn Clinic, which is part of the Bridgend Health and Wellbeing development, as part of a land swap deal to Link Cymru on the 1st of April. And the remaining 2 clinics at Corolla Road and Bryn Tyrion will also transfer when we complete work later in the year. And then as part of the ongoing estates rationalisation work, we have now identified Pontypridd Cottage Hospital for disposal. Services now confirmed with plans to vacate, and so I'm recommending that for approval by the board for disposal through the normal routes.
Thank you, Sally, for such a comprehensive update. I'll bring Paul in next, and I'll come to Patsy. Thank you.
Just on the Ponty Cottage Hospital, I guess we should agree that here, but I think we might just want, Simon, we might just want to think about communications plan around that, because it's obviously a much loved building in that local community, and we'll just need to think about how we probably might want to do some engagement with elected representatives about that. It's just not because, candidly, there aren't any, so to speak. Well, what was there is very small, and it's been reallocated into other areas, but I would suggest we might just want to make sure that we've got a clear engagement and communications plan. So we agree it's in principle, but subject to a communication plan.
And the first step is to put it onto the public sector protocol, to put it on the NHS Wales Estates database, and then any public sector partners who wish to express an interest can do so.
Yeah, thanks, Patsy.
Just interested in the targeted estates funding, the nearly 4 million top slice. We then bid against that, don't we? And historically, have we done really
so
well?
This is part of a 2-year programme that was agreed. So the 4 million represents our 30% share of the targeted estates fund. So it then gets topped up by Welsh Government funding. So it sort of gets taken away from us to give it back to us.
Yeah, that's what I mean. We then get.
So we've already got those approvals in place, and the schemes are sort of up and running. They did it on a longer, multi-year basis, which is helpful when you're trying to run these schemes.
Yeah, 2 questions on the Ponty Cottage Hospital. The restricted covenants, is that going to be an issue?
Yes, potentially it will be an issue.
Yeah, and what happens if nobody wants to purchase it?
Well, then we need to think again about what we do with it.
Well,
yeah. And hopefully there are often restricted
covenants. And there's some options out there to try and resolve that.
More tends to affect the value.
Okay, thank you. The other question I had was, obviously this is going to be our largest capital programme sometime, or ever, I don't know. Ever, right. Just in terms of, we talk about kind of the small but fantastic capital team we've got. Can we capitalise more salaries and have we got enough staff basically to kind of cope with what we're facing moving forward?
We do
it's really exciting, but huge challenge.
We have some specific teams around PCH ground and first floor that will start to taper off as we move forward, because the intensity of the scheme is actually reducing. We do have a team around Lanchester Health Park. We have some people associated with some of the other RCF initiatives as well. It is a small team, it's 10 in total. If they're very experienced, we are trying to build that capacity in. What I think I've tried to represent to Welsh Government colleagues is that if we had more certainty up front, i.e. a bigger discretionary allocation, we could make more informed decisions about how we could recruit into longer term posts. The fact that we're constantly bidding for monies later in the year means that it's really difficult to go and bring in capacity because we don't know. We don't know that the funds are going to be available. So I think for me, I would really strongly represent that we should have a larger discretionary allocation that allows us as a statutory organisation to plan to cover our statutory requirements around replacement, estates, backlog maintenance, all of those things. And then we could resource the team adequately. And we did reflect last year to Welsh Government when we weren't able to take some additional funds later in the year because we didn't have capacity, that reflected the sort of process for how money flows out.
Just I'm watching brief, is it?
It is,
at the moment, and trying to.
I think it's just representing that if you looked at the equivalent size organisation in England, you would be seeing a discretionary capital allocation. So if I looked at Cornwall, which had a similar sort of population for the one DGH, and across the community I had a £25 million discretionary, and then I arrived here with 3 DGHs and it was 8. It's a huge amount of work that we have to get. All the risk we're managing as duty holders across our estate, 8, 10, 12, 13 million is a very small amount of money. And of course, what is being bought by it, our buying capacity is reduced with inflation, which has been significant in this arena. So I think trusting health boards to be able to run their programs would be really helpful.
Okay, unless there are any other questions to Sally on this item, can I propose just that we note those items that are listed for the noting, which includes obviously closing the 25-26 position, noting the discretionary plan for this year, and the allocations approved and anticipated as included in the IMTP for this year. We'll note the progress on major capital schemes and disposals for 25-6 and 26-27, and also the scale of the expanding capital programme and the significant delivery challenges that will need to be carefully managed across the health board, recognising that we are now spending, increasingly significant amounts of public money to improve our capital estate, which is to be hugely welcome because it has a massive impact beneficially for both our patients, their families, and importantly for our staff working in those environments. That makes a huge impact, has a huge impact on them as professionals. Can I also ask the board to approve the disposal of Pontypridd Cottage Hospital? Thank you very much. Item 8, the consent agenda. There are those items listed at 8.1.1 to 8.1.3 for approval. Thank you. And for noting at 8.2.1 to 8.2.5. There is some additional business which I do need to cover off this afternoon, and it's in relation to a number of questions that the board has received. As I mentioned at the outset of the meeting, we had received questions in relation to items that were not specifically on the agenda today, although they have been referenced by the Chief Exec and by me as Chair. We received some questions in relation, to start with, to the sufficiency of current GP capacity in the area to meet the increased demand associated with the Porthcawl waterfront regeneration programme. So the Health Board has shared the same response shared with the Communities, Environment and Housing Overview and Scrutiny Committee of Bridgend County Borough Council back in February of this year. And this confirms that the Health Board does not foresee a requirement to invest in additional GP provision, whether a new building or a new general medical services contract in Porthcawl, as the anticipated primary care demand can be met by the Porthcawl medical practice. The other issue which we received questions on were in relation to the ongoing health visitor dispute. And I will read the questions and the answers received in relation to this issue. We have received these questions from two members of the community. Now, both questioners have asked, firstly, what is being done to resolve the ongoing industrial action? So the Health Board remains committed to resolving this matter through constructive and meaningful two-way dialogue. The Health Board has engaged with Unite through appropriate channels, including local discussions and ACAS facilitated meetings to support structured engagement. At the most recent ACAS meeting on the 30th of April, Unite confirmed that it was not willing to consider any resolution put forward by the Health Board other than the rebanding of all health visitors to Band 7. Unite also confirmed that it remains unwilling to participate in the National Expert Partnership Group established to review health visitor job descriptions across the whole of NHS Wales. Whilst this was disappointing, the Health Board remains focused on securing a timely and sustainable resolution whilst maintaining critical services for families and communities. This includes progressing work on consistent all Wales job profiles and meaningful career pathways for health visitors. Furthermore, the Health Board remains open to holding discussions with Unite about alternative potential options for resolution. In addition, the first questioner has asked the following three questions. Is there a problem with misogyny at senior levels blocking meaningful negotiations? The Health Board does not recognise the characterisation that there is a culture of misogyny influencing decision-making within the organisation, and such an assertion is taken extremely seriously. It is also important to note that the Health Board's workforce is predominantly female, including across many professional and leadership roles, and we remain firmly committed to fostering an inclusive and equitable environment for all. The Health Board is confident that its processes are grounded in fairness, equality, and adherence to NHS values and policies. Decisions are made through robust, objective governance arrangements, including partnership working and adherence, of course, to agreed job evaluation frameworks. The Health Board remains fully committed to ensuring equality, inclusion, and dignity for all staff. The next question is, why isn't the Band 7 job description being honoured after being agreed in partnership with the Independent Job Evaluation Group? It is important to note that there is not an agreed Band 7 health visitor job description, which has been agreed in partnership with CTM or any revised All Wales job descriptions. Whilst the Health Board recognises the concerns raised regarding the revised NMC educational requirements, a Level 7 qualification does not in itself determine Band 7 status under agenda for change. The Health Board has been clear that this is a broader issue that cannot be resolved unilaterally at a local level. Any such action taken unilaterally within Cwm Morgannwg University Health Board would risk creating wider implications across other health boards and staff groups beyond health visiting. Following on from the decision to archive the national health visitor profiles due to the NMC change, an All Wales Expert Partnership Group has been established to develop a suite of health visitor job descriptions which all NHS Wales organisations will be able to utilise. To date, Unite has declined to participate in the Expert Partnership Group, despite being asked to do so by the Welsh Government's former Cabinet Secretary for Health and Social Care. The significant and vital role that health visitors play is recognised by this Health Board, and we remain committed to resolving this issue in any way that both maintains service stability and recognises the professionalism of our workforce. However, any future role changes must be agreed across Wales and must therefore meet future service needs. The suite of job descriptions developed by the Expert Partnership Group will define a clear and structured professional career progression pathway for health visiting across Wales. The fourth question is, why is Howard Daniel ignoring the Welsh Government's instructions to honour the Band 7 job description? Contrary to communications issued by Unite, there's been no written or verbal instruction from Welsh Government directing the Health Board to take such action. This has been communicated directly to Unite representatives on more than one occasion and was also shared with ACAS during discussions. Welsh Government's stated position remains that the nationally agreed job evaluation process should be followed and that trade unions should engage with the expert partnership group. Claims suggesting otherwise are inaccurate and risk creating unnecessary confusion among staff and the communities they serve. We are satisfied that the organisation continues to act in line with the Welsh Government expectations, national guidance, established policies and the NHS job evaluation scheme. We have been in contact with Unite to address ongoing points of inaccuracy and issues relating to respect and fairness in their communications, most notably on social media. We respect the right of staff to take strike action, but we must also ensure that colleagues who remain at work are treated with the same respect. We have also received questions raised by a second questioner who states that they are writing as a parent of a baby within Cwmtarth Morgannwg University Health Board area to raise serious issues about the ongoing disruption to health visiting services due to industrial action. They say that whilst they understand that this is a situation which arises from a dispute, the impact on families like mine is significant. The reduction or suspension of routine services leaves parents like them without essential guidance and reassurance during a crucial stage of child's development. And they've asked for clear answers to the following questions. Firstly, health visitors provide a vital safeguarding function to schools within Cwmtarth Morgannwg. Has the removal of this function been identified as a risk? And if so, what mitigation has been put in place? While health visitors provide a vital safeguarding function within their role, safeguarding is a fundamental responsibility shared by all professionals working with babies, children, young people and their families. Although the health visiting service is currently operating an essential service model, safeguarding remains a core priority. This continues to be delivered with the support of the corporate safeguarding team and in close collaboration with local authority partners. Schools also retain access to the single point of access line, enabling direct contact with a health visitor with a 2-hour response time in place. To provide further assurance, every school across the Cwmtarth Morgannwg footprint is supported by dedicated specialist community public health nurses who offer advice and support to the school community. In addition, each school has a designated member of staff responsible for safeguarding, supported by dedicated safeguarding professionals within the education authority. Together, these arrangements ensure that safeguarding responsibilities continue to be effectively upheld. The next question we received was, what is the expected timeline for restoring full services? United issued a further strike notice until the 17th of July this year. We will continue to press for the work of the All Wales Expert Partnership Group to progress at pace, and we urge Unite to participate in these conversations to help shape the future design of health visiting services in Wales. And the final question from this individual is that I've been made aware of concerns that health visitors may not have been paid for work undertaken whilst not on strike. Can you clarify whether this is accurate, and if so, how this aligns with employment law and your duty to resolve the dispute and restore services for families? To clarify, health visitors have been paid appropriately and in full for all periods during which they were not participating in strike action. This includes authorised periods of annual leave and sickness absence. However, in line with established employment practice, any days on which individuals took part in strike action are unpaid, as employees are effectively withdrawing their labour on those days. We are not aware of any cases where staff have not been paid correctly for work undertaken. If specific examples are brought forward, these will be reviewed promptly to ensure any discrepancies are resolved. We remain committed to acting in accordance with employment law and to working constructively towards resolving the dispute and restoring full services for families as quickly as possible. As chair of the board, I was keen, along with colleagues this afternoon, to ensure we placed that on the record for us as a board, and of course those responses will be issued, if not already done so, to the individuals who raised those specific questions. Item 9.2, meeting feedback. In the attempt to refine and improve our meetings, any feedback is welcome, and please do so within the next 2 weeks of this meeting if there's anything you wish to raise. Item 10, there's no requirement for a private or in-committee session on this occasion, and the date and time of the next meeting will be the Thursday, the 25th of June, to approve the annual report and the annual accounts for 2025-2026. However, the next scheduled regular meeting of this health board will take place towards the end of July, in addition to that one in June. Rydw i'n dod y cyfarfod y bwrdd iechyd y ben, a hofyn y diolch gyfar sydd wedi ymuno yn ei gwylio cyfarfod heddiw. I now bring the board meeting to close and would like to extend my thanks to all those who have participated in this meeting or who have observed our proceedings virtually today. Thank you very much. That concludes our meeting.
We are no longer live.